All right. Good morning, everyone. Until we are done. We are far behind time. Yesterday we said we were going to convene at 8 a.m. today, and by my estimation, it's already past 9. So I think we have to go through it quickly so that we can get time to do all the other things. So we are going to call on stage now for an abstract presentation. We are going to invite Madam Pamela Wamalwa, yes, to come and then deliver her abstract presentation. Please put your hands together as we invite her on stage. Oh, do you have a problem with her? Does anyone have a problem with her? Put your hands together. Yes, clap, clap.
Have you ever wondered why some conditions that you learned about in college are not mentioned in your areas of practice? Or maybe sometimes you encounter a condition in the outpatient and you have this feeling of deja vu, like, I've seen this condition, I know it, but actually you don't know it. Our distinguished guests, fellow clinical practitioners, ladies and gentlemen, my name is Pamela Machuma Wamalwa. I'm a reproductive health clinical officer, and together with me is Sister Rose Wasike. She's a pediatric clinical officer, and the sub-county clinical officer, Dagoretti sub-county. Both of us are from Dagoretti sub-county in Nairobi County. Our topic is knowledge of our topic is knowledge of neglected tropical diseases among clinical officers in the larger Nairobi West region. And we are looking at we are actually doing a general evaluation of clinical officer knowledge and understanding of neglected tropical diseases. Now, what are these neglected tropical diseases? They are actually a diverse group of conditions that are caused by viruses, bacteria, toxins, and even parasites and fungi. And they have they're associated with devastating health and social economic consequences. And this group of conditions, they are very subtle, and some of them are not even known that people are having them until we see the outcomes or the impacts or the effects that they have on the affected people. The epidemiology of these conditions is complex because some of them, mostly they are associated with the environment, and some of them, their transmission involves vectors, and they have a complex life cycle, and all these factors make it very difficult and challenging for public health interventions. When you look at the prevalence globally, these conditions mostly thrive in tropical climates, and especially in communities which are impoverished, and they have no access to sanitation and clean water, which is essential. According to the WHO, at least 1 billion people are affected by neglected tropical diseases, and at any given point, we have 1.6 needing intervention. That is both prevention and treatment and management of these conditions. And now when we talk about neglect, where is the neglect? These conditions, mostly, when you look at the agenda, the global health agenda, they are almost absent on the agenda, even though they have this devastating impact. And when you look at the resources that are needed for them, those people who play a key role in funding these conditions, it is not even among those that are considered for funding. And we come at the community level because of their effects. We are looking at conditions like elephantiasis, We are looking at conditions like trachoma. We are looking at conditions like leprosy. We are looking at conditions like Brody ulcer. These conditions come with stigmatization. And therefore, people are not free to come out and say, okay, we have this condition, bringing stigma. And when people can't come out to show that we have this condition, how do we intervene? And those are the challenges that we face with the neglected tropical diseases. Now, our focus is Nairobi County. And in Kenya, we have about 18. Generally, worldwide, the WHO has listed about 21 conditions in this list. And in Kenya, we have an endemicity of 18 entities. And they actually pose a very major public health issue, and they impact many conditions, especially in the areas that they are. Now, Nairobi is a cosmopolitan county. It hosts people from all over the country. And these people come, most of them come to live. Majority of a bigger portion of their life is lived in Nairobi because they come to fend for their lives. And most of them come from areas that are endemic. And therefore, they could be carrying these conditions, and we don't know. These people need to be attended to. Now, the role of clinical officers in management. As we know, clinical officers are frontliners. We are the first contact to clients. Therefore, we play a very essential role in the prevention and management of these conditions. Therefore, it is essential that we increase the knowledge of entities among us, health professionals, especially clinical officers. Together with implementation of effective strategies, we can reduce the burden of entities. Now, the study objective, we actually wanted to understand the knowledge of clinical officers on neglected tropical diseases in the larger Nairobi West region. The assessment was to evaluate the understanding, attitudes, and practices of clinical officers towards neglected tropical diseases. The research design was implemented. We implemented a cross-sectional approach so that we gather a diverse insights from the clinical officers. Our area of focus was the larger Nairobi West, which includes the Dagoretti, Lang'ata, and Westland sub-counties. It is also important to note that Lang'ata sub-county hosts the largest slum area, which hosts these vulnerable communities. The sample size, we have a total number of 126 clinical officers in this region, and 100 participated in this survey. The method of data collection was self-administered questionnaire, which was which was sent to all of the clinical officers in the region, and those who answered who responded were 100. This is a limitation I would want to note at this point, because if we had a larger area coverage, we could get a bigger picture, a true picture of this survey. But we were just doing it without any support, no funding. It is a self-initiative. Our analysis was through a descriptive statistics in Excel for comprehensive interpretation. So we were looking at 5 dimensions in this survey. The first dimensions was the general knowledge, just general knowledge about neglected tropical diseases. And we looked at the factors that are associated with the prevalence of neglected tropical diseases. And actually, as I mentioned earlier, poverty, mutation are major. And realized that 93% of the clinical officers were alive to this fact, that actually these conditions are associated with poverty and poor sanitation. When now we looked at the prevalence, how many clinicians were able to identify the number of entities in the country, we only had 8% who were able to say that actually we have 18. Back in 2018, they were 19, and then we were declared, guinea worm was declared eradicated in Kenya, so we moved to 18. And then we were also looking at the populations that are most vulnerable to these conditions. And as I mentioned, well, I have not mentioned, yes, and we had 20% of clinicians identifying children as the most vulnerable to these conditions, which is a true fact because of their habits. We cannot control where children are playing. they are vulnerable to get these conditions because of the sanitation. We are also looking at the conditions that are on the index for tracking by the WHO and for our country according to the strategic plan 2020. After Sacariasis and lymphatic filariasis. Another dimension was identification and management of this. And this area we are looking at the confidence level of clinical officers to be able to identify and manage any neglected topical disease. And here we got 31% of clinical officers who are confident, which means 69% were not confident enough to identify and manage neglected tropical diseases. And then we're also looking at awareness and definitions of these conditions. And 13% did not even know what neglected tropical diseases are. And then we asked if any had encountered any neglected tropical diseases in their service. And in our survey also, we were looking at the years of experience. And most of them, of the clinicians, were between 5 to 15 years. So 54% had ever encountered and suspected and managed the NTD patients. And then 33% encountered and referred them for specialized care. And that indicates the complexity of these conditions and how we do our referrals. And then we looked at the familiarity and treatment protocol for NTDs, and we had 23% who lacked the knowledge of how to manage these conditions, even though here we have 54 who were able to suspect and manage these conditions. And then we also looked at the disease transmission and unique statistics of among the listed conditions, clinicians were able to correctly identify hookworm as not being vector-borne condition, not being a vector-borne condition, because we can be able to differentiate those are directly transmitted and those that need vectors. And we're also looking at the vector habitats for NTDs, and 71% were able to recognize that schistosomiasis and it's also important to note that even though dengue fever can actually cure or heal in the first episode, it is very risky to get a second episode because it could be fatal. And for our second last dimension, we are looking at intervention measures in the management of NTDs. And among the questions that we asked, we found that 35% of the clinical officers were not aware of the level of isolation in the prevention protocols. And 38% were not able to know when are we able to do isolation of patients to infection. And this actually is supposed to be done when in the period of communicability in the progress of the disease. And then we are looking at the sanitation influence on infections like Ascaris lumbricoides. and 53% links environmental sanitation to the spread of Ascaris, which is a true fact. But that, the 47 could not tell. All these are indicating the gaps that are there to be looked at. And then recognition of mass drug administration, MDA, as on the target populations. Okay, mass drug administration is one of the ways that we use in control of some of the neglected tropical diseases, especially STHs, that is soil transmitted helminths, and schistosomiasis. So the target population is in areas where there are what is the role of alcohol and hand gel. And this is 7% incorrectly identified alcohol gel as a cleaning agent, which is not actually true, because a hand gel can kill, yes. Provide in-depth knowledge on neglected tropical diseases, prevention, diagnosis, and treatment. Another thing that we can do is to strengthen the curriculum, that is revised medical training curriculum to include updated information and practical skills related to neglected tropical diseases. We can also do regular CME programs. Therefore, we conduct them focusing on NTDs to keep clinical officers updated on the latest advancements. And in this, I want also to mention that we have a lot of information online, especially on the WHO website, where we can even have apps that can guide us in management of some of these conditions. We have organizations that are working on these entities, including the Global Institute for Eradication of Diseases, that is GLIDE. And then we have the END program that is also focusing on NTDs. We have organizations like JICA, we have organizations like the Carter Center, which are also doing a lot on eradication of NTDs. Therefore, by improving or putting this intervention in place and addressing knowledge gaps among clinical officers, we can enhance NTD control efforts, leading to better patient outcomes and disease management. So these are my references. I would like to acknowledge the Nairobi City County Government, especially the Chief Officer Public Health Services, that's Mr. Tom Nyakaba, and the Director of Clinical Services, Nairobi County, Mr. Geoffrey Tumaini. The Sub-County Clinical Officers, for Dagoretti Sub-County, Sister Rose Wasike, for Langata Sub-County, Domitila Ogaro, and for Westland Sub-County, Judy Nkirote. I also want to appreciate all clinical officers who responded to this survey, those who are on the pilot and on the actual survey. And lastly, I want to appreciate the Health Promotion Officer at Dagoretti Sub-County. Thank you very much.
Thank you very much, Pamela. Please, let's give it up for her again. Xavier is not here to... So let's just... Yes. Okay, so at this point, we are going to take 2 questions from the audience. You understood perfectly what she spoke about. So for the first time at this conference, an abstract presenter has no questions. Are we going to make that history? Scott. Scott says no. Okay.
Thank you, Pamela, very much. I really appreciate what you're presenting. And for me, studying as a physician associate in the United States, all these diseases are very new. So I'm always impressed with the education and the training and the clinical diagnosis, that's made here with these types of conditions. Just maybe I missed it in the beginning, but I've never heard the term neglected tropical diseases. Why would these be neglected as opposed to important diseases that must be tracked and must be diagnosed as such? Thank you.
Yeah, I want to say, Scott, I was in the same position as you are. I never knew that they actually exist. And one day I meet a colleague who says, Pam, there is this training that is going to happen in Egypt. It is on neglected tropical diseases. And then I look at the qualification of people who are supposed to go there. There are epidemiologists. There are people in the public health domain running programs. And I said, let me just put my name there and see what happens. So I applied, and good enough, I was allowed to go. And I was trained for 1 month at the Ain Shams University, Cairo, Egypt. And this is the information that I came back with. It opened. Actually started seeing elephantiasis, most of elephantiasis on the streets as I was walking. My eyes were open to see these conditions. I even saw a condition called NOMA. I had it for the first time in the training, and I saw it in a place called Kigomba, Nairobi. So it is a big market. So it is an eye-opener. And that's why I decided to do this survey and to see how many people knew this. Before I did the survey, I could encounter our clinical officers and ask, do you know neglected tropical disease? And they're like, what? Pam, we saw you somewhere. What were you doing? I say it is neglected tropical disease. And they also say it is not. So I just wanted to get a background on the knowledge so that this can inform.
Hello? Hello?
Hello.
Hello?
So that there could be interventions for so I can just continue minus this. Yeah, so why I'm giving you this history is so that we know the chronology. And where is the neglect? These conditions, I will take, for example, lymphatic filariasis. It is not easy to know that someone has lymphatic filariasis until the complication sets in. Therefore, when you follow history, we realize this infection could even be in childhood, as the children are playing. Then someone gets these wounds. What they go to block lymphatics. And after a period of even 10 years, that is when you see the impact of the condition. Because now the complications have set in, and no intervention can change this. These conditions, because of their slow progress, they are not given the weight like the acute conditions. Because you look at something like tuberculosis, we look at something like malaria. They are very fast progressing. Their fatality rate is very high. Therefore, our efforts are focused on these ones because they can easily cause death. But we are not looking at these conditions, but they really alter the quality of life and expectancy. Because someone with trachoma who has been blinded cannot fend for themselves. They cannot, they cannot be of economic impact. They cannot provide for themselves. So here is a person whose life has been altered, both socially and economically. Look at elephantiasis. Therefore, at this moment, we have to focus on these conditions, that even when we are alive, we can live a quality life, free of disfigurement, free of impairment. I mentioned a condition called NOMA. Noma can actually, or usually affects the mucosa of the mouth and the nose. You can even have teeth protruding from your cheeks. How do you face people and how do you live? And that is why I bring this so that it can be focused on and people live a quality life.
Okay, thank you very much. Okay. This is the last question anyway.
Mine is not a question, but basically to help our colleagues got why they named it neglected. It's because at some point, these were diseases labeled for Africa initially, in other words, the tropics. And then at some point, governments thought they had dealt with them. So they were kind of being wiped out. But and then these other communicable diseases were emerging. So focus shifted from them to the more emerging communicable diseases. And that's why they termed them neglected at that point. But majority of them are under entomology. So that's why we do not focus so much on them as clinical officers, because they have a whole department under entomology. Things like podoconiosis is rarely seen, but it does exist. And we've seen many of them in one of our districts in Kamwenge. And it's because these people move to these gardens and then they get exposed to the heavy metals. If you see them, you may think it's elephantiasis, but yet it's not. So we need to do more surveys. Maybe for the case of clinical officers, we need to simply be enlightened, but they do exist under entomology. Thank you.
Thank you very much, Doreen. How many people from? No. We were taking only 3. I asked, there was only 1 hand that came up. You are the last question, please. Thank you. Who's taking it?
Yes, good morning. My name is Anderson Ngala from Kenya. I'm a TB and leprosy coordinator. And my observation is that we have leprosy, which is under the TB and leprosy program, but I feel it's neglected because they pay a lot of, they concentrate on the TB and forgetting the leprosy part. So I feel it should be included in the NTDs. Thank you.
In addition, a neglected tropical diseases. I was going through your presentation, and now that the Clinical Officer Council is here from Kenya, according to your data and those who participated in the survey, do you think higher national diploma tropical medicine can be of help in Kenya?
I'll go with the first. My voice, okay. So leprosy is actually on the list of neglected tropical diseases. And TB is given weight more than leprosy because of the prevalence. There are very high numbers of TB as compared to leprosy. And there is a threshold of 0.1% for a condition to be put of public interest or to be focused on, which leprosy, according to indices, is a little bit below that. And about a course on neglected tropical diseases, that is I don't have the dispensation to decide on.
Okay.
Thank you.
Thank you so much. Mine is to reiterate whatever my brother has talked about here concerning the curriculum. I happen to have been given a unit this coming semester to teach tropical medicine in a local university in a clinical, BSc clinical medicine. And I agree with him. I think as curriculum developers, the council, the clinical officers council, KMPDC, and the nursing council, I believe your presentation has really opened my eyes. And it's a high time we approach those donors and other relevant stakeholders in education or curriculum developers to come up with a competent and concise curriculum on tropical medicine that will encompass not only NTDs, but other tropical diseases that may arise as a result of climate change and global warming. So, my brother, you are right. I think it's a high time as stakeholders to come together and come up with a concise curriculum on tropical medicine that will encompass both NTD and other emerging diseases as a result of global warming and climate change. So thank you for the presentation.
Okay.
Thank you very much. My name is Manasseh Bocha from Ministry of Health, Kenya. For those who are coming from Kenya, you know very well that we have a whole master's degree in tropical medicine and infectious diseases from GACOPA, Jomo Kenyatta University. So the program is already there. What is missing is the applicants. So I want to challenge all of us, those ones who feel that they have qualified, apply. It is open to clinical officers at GACOPA. And we want to welcome the region. Those of us who are coming from the other countries, come to Kenya and do a master's degree in tropical medicine and infectious diseases from Jomo Kenyatta University. It is available there.
Thank you very much. I think this is the end for Pamela. Oh, you want to add something small?
With your permission, I want to take to also note that with the changing climate, as I mentioned earlier, most of these entities are vector-borne, and the changes in climate is also changing the patterns of vectors. As you can see in Nairobi now, we are being told that there are mosquitoes now in Nairobi that can transmit malaria even without visiting the endemic areas. That also has to be put into consideration. And clinical officers play a major role, even when the other the other cadres who do diagnosis come in. We are the ones who identify and then they confirm the cases. So it is really vital that we are informed. Thank you very much.
Thank you very much, man. Please, let's put our hands together for her. Oh, we can do better. We can do better, please. Yes. Or you want to get up? Or you want together for him, Doc. All right. Oh, please. Do you have a problem with him? Put your hands together for him to see it.
Thank you so much. Good morning, delegates. I want to start from where Pamela has stopped. Climate change. I want to go through to sensitize us about climate change. My name is David Jero. I'm a lecturer at Egerton University in Kenya, one of the 15 universities that train I have a bachelor's degree in disaster management and a master's in occupational safety and health. I don't know what comes to our mind when we hear the word disaster and we just talk about it, and maybe as clinician, we don't think that we have any role to play. I'm happy that Pamela has tried to link some of the conditions with climate change. Contrary to what we, at every time we are in a disaster phase, and there are 8 phases of a disaster. During the state of normalcy, when things are normal, that's the time when people don't think warnings. And then after that, there are some disasters that can't be prevented completely. Like human-caused disasters, they can be prevented through various strategies. If it's not preventable, then it can't be mitigated, lessening the impact. If that is not possible, we prepare for the worst. What people call disaster is the fifth phase, which is disaster emergency. During that phase, there is very little you can do. It's the most chaotic, the most confused, other than just rushing and maybe collecting bodies, doing triage, giving first aid and emergency medical care. But that is not where we should start. That is what we should prevent. Then, of course, after that, you go to rehabilitation phase, and then you start disaster reconstruction, going back to the state of normalcy. That is the disaster cycle. And at every one stage, as clinicians, health workers, we need to think what is happening at our area. It's said that if you want to learn something, read about it. Read about disasters. If you want to understand something, write about it. If you want to master, then teach. I'm not about to teach, I just want to make a presentation. There are 3 types of disasters. They're classified as natural disasters, technological disasters, and human-caused disasters. Of course, there is a very thin line between technological disasters and human-caused disasters, because in many technological disasters, there is a human hand in it, but maybe not directly. So climate change is one of the natural disasters. It's affecting every country in the world. There has been several meetings, summits rather, heads of states meeting in many parts of the country to try and mitigate or discuss how they can mitigate the disaster issues. Last year, it was COP28, the Conference of Parties. That means heads of states and governments have had 28 meetings, but there is no impact. It's in fact worsening globally. So what is not being done right? Maybe we don't have technical people, because you look at some delegations going to these summits, out of 300 and something, it's nobody who has technical knowledge about disasters. I think it's time to change when we go to COP29, which will be held this year. So climate change is the talk of the day. Erratic weather conditions, very hot, very cold, floods, new diseases, and unfortunately, it will take a very long time before we combat this, because it's not a one-off, not like a clinical disease. You make a diagnosis, put the patient on treatment, and then it goes. It requires small activities to address the root cause of the changes. So these diplomatic meetings have been held and many committees formed, treaties signed, but still there is no impact. What we are talking about is emission of greenhouse gases, the notorious being carbon, nitrogen oxides, sulfur oxides, chlorofluorocarbons, etc. So we need to know where are these gases coming from so that eventually they cause the climate change. Unfortunately, we cannot have boundaries to control climate. And that is why there is need for international collaborations among United member countries and non-UN member countries to address the climate change. So, health sector. Does the health sector where we work contribute to climate change? It does. And you'll find that about 8.5% of all the greenhouse production comes from health sector. It may look small, 8.5%, but it's a contribution. So as health workers, what can we do where we are working, in the facilities in which we are working, in order to reduce this? So I'm only emphasizing that as clinicians, we have a role to mitigate the carbon footprints in the areas where we work. So the objective of this study was to examine the contributions of health sector towards air pollution. The specific objectives were to determine the sources of greenhouse gases, to evaluate existing mitigation measures, to document the health impacts of the climate change, and to explore the role that health workers, including clinicians, can play. This was a desktop review. I went through several published articles, both peer-reviewed, gray literature, etc., which is recent. There is much that has been published, but unfortunately, I don't know what happens when it comes to implementation of the recommendations. So, what are the sources within the health sector? Of the 8.5%, 70 to 80% in the health sector come from indirect emissions. Indirect, we know transport is one major source. You have supplies of drugs, supplies of foodstuffs, your own vehicles, visitors, etc. Yeah, those gases produced. Ambulances, etc., etc. Then in the hospital care, some of the procedures that are done within the hospital contribute in whichever small way, including diagnostic procedures. Maybe you are using energy, you are using light. Where does this light come from? The source of this must have left some carbon footprints. Diagnostic procedures, some treatment, investigations in radiology, physiotherapy, and even in some medical equipments. Operating theater. This is a very important unit within every health facility, and it produces about 30% of the facility's waste, and 2/3 of the regulated medical wastes. These are the ones that are prescribed, has a specific way of disposal. We find that theaters consume 3 to 6 times more energy per square foot than anywhere else within that facility. We are talking about a health facility. Pharmaceutical and medical products, in a small way, whether prescribed or non-prescribed, they contribute towards the production of gases. An example in Canada, greenhouse gases emissions in Canada, about 22% of the healthcare-related carbon dioxide emissions in Australia. These are the comparative between some of the developed countries. As much as Africans are sufferers of the climate change, but we also produce in our own small way. Chemicals that we use in the hospitals, whether in management, whether in cleaning, whatever type of chemical. You think about where it is being disposed, where it came from in the first place, disposal, etc. It has some contributions towards these changes. This is general waste in the hospital. When it decomposes, production methane, how do we dispose of the wastes that we produce in the hospital? Are we observing the principles of 3 R's? Reduction in the production of waste, recycling, and principles of 3 R's. Reduce, recycle, reuse. The mitigation measures. What can be done within our health sector? And a study carried out in 2015, which focused on cross-sectional linkages between adaptation and mitigation measures focusing on Europe, is the one that I reviewed. And it showed that fossil fuels, electricity and gas used by healthcare services are 2 main sources of carbon dioxide emissions. The impact of climate change can be looked at from various aspects. One is the natural aspect, where we are talking about climate variability, which has led to food insecurity in many parts of the country, either because of floods or droughts. Extreme weather phenomenon, very high temperatures in some areas in Europe. I think we have lost so many people because of heat-related complications. New epidemics. There are some diseases that are not following the normal trend, and mutation occurs because of these variations. There's a summary of the impacts of the climate change. If you look from the nuclear, where the change occurs, you can have rising temperatures, whose impact are shown here. More extreme weather conditions. We have rising sea levels, coastal floodings, which now moves to the next level. Extreme heat, temperatures, severe weather, air pollution. Extreme weather has led to changes in the pattern of these diseases. Malaria, dengue fever, Rift Valley fever, chikungunya, West Nile virus. Respiratory diseases and allergies, like asthma, have increased. Then we also have the water impacts, cholera, cryptosporidiosis, etc. Water and food supply impacts, including malnutrition due to food insecurity, diarrheal diseases where there are floods, forced migration, civil conflicts, mental health issues, they are on the rise. Then we have heat-related illnesses and death, including cardiovascular diseases. Maybe I don't know this. It's a slide that came earlier. So mitigation, what can be done in whichever small way? One is to prioritize as corporate and board, the goal of decarbonization in the healthcare value chain, from the source of your product up to the consumption, by the patients or whoever. 2, improving energy use. Much of the sources is from energy, and I don't think I want to overemphasize on that. The use of clean energy is what is being advocated for. Participate in relevant industry coalitions to collaborate. You cannot work alone. There has to be collaboration between all the industries, health sector, manufacturing, agriculture, etc. Then generally reducing the carbon footprints in the hospitals. Preparing facilities for climate impacts. Is during the disaster preparedness, what can we do in order to anticipate or to mitigate extreme weather conditions? Using trusted voices. This in community education in order to increase the resilience of the community and create awareness. Clinical officers are trusted within the community. If you educate your members, many will accept and agree with what you advise. Sorry, that's repeated. In conclusion, the health sector contributes significantly to climate change. Global warming is like a symptom of climate change. The health sector has a unique opportunity to leverage its position and resources to provide comprehensive strategies for achieving better individual, community, and the whole planet in climate change issues. So the recommendations arising from this study is that there is an urgency for healthcare managers to drastically reduce their businesses' value chain emissions. Then we need inter-industry and inter-sector collaborations, alignment around the key action items will ensure transition of healthier, safe, and cleaner health sector that will uphold commitment to do no harm. Then considering the large variations in how healthcare systems are organized and perform, it is also necessary to identify system-level interventions which can improve the environmental sustainability. And lastly, more research on costs and benefits of strategies and on how the factors facilitate a change for more sustainable health delivery are urgently needed. Thank you very much for listening to me.
Thank you very much, Dr. David Njeru. Please, at this time, if you have any questions for Doc, you put up your hand. Go in. Go in. Scott. Scott starts, and all of a sudden, 3 people will raise their hands.
That's what we need, a little motivation to happen. Dr. Njeru, thank you. This is such an important topic, and different conferences I've been attending around the globe have started to include this, the health crisis that's happening due to global change. But I'm always kind of struck by the immensity of this. It's such a huge problem. Where do we begin? How do we as a single person, how do we as a clinician, an educator, as clinical officers, PAs, make a change? What do you recommend? What is something that's tangible and possible for us?
Thank you for that. Like I did mention, this is not a one-off. It requires concerted efforts. People need to be sensitized at all levels. In my university, we have introduced disaster management as a course to sensitize the students at that level so that maybe they can develop interest and even go at master's level. And it's from there that information is disseminated to the ground. What is important is to be sensitive about the cycle. What can we do during this area? during this time. Two, and that becomes political, by definition of disaster, it is massive disruption of people, of the community, environment, and the infrastructure beyond the capacity to overcome, and hence requires external support. So we need to improve the resilience of the community so that they are able to overcome. In Japan, there is always, they expect earthquakes, for example, every 2 to 3 months, because they are on that line called the Ring of Fire. Japan, Indonesia, that line. But you look at the impact of disasters in Japan, there is very minimal death because of their resilience, the way they construct their buildings, the way they prepare for the earthquakes. So we are talking about improving the livelihoods and resilience of the community, educating the community, and that reminds me there was a very important meeting or conference that was held in Japan, Hyogo town, in 2000. And they came up with a very good framework on how to address all this. It is called Hyogo Framework of Action, 2000 to 2015. If it was implemented, we would not be experiencing what we are experiencing globally. So sensitization as AIPA include disaster management as part of the training in the curriculum.
Okay, thank you. You see now. Thank you very much, Scott. How many? I'll come back to you, okay? Please, let me go out there.
Thank you, Dr. Njeru, for the good presentation. And I think what you've stated is issues about disaster causes and especially environmental health issues. And I was just sitting and imagining as GACOPA, as clinical officers, associations, unions, clinical officers, councils, what is our contribution in terms of environmental conservation? Do we have a role? And if we have a role, can we have a program on how to action it? Because we should not just be complaining about our contribution to the carbon emissions within the environment and degrading our environment, because as hospitals, we are the ones who are contributing significantly into pollution. But can we also be part of the mitigation measures? What programs can we be able to think about, like tree planting and others? Do we have programs as an association or as GACOPA or as clinical officers council?
Very good. I think, Honorable, I think that is very good. It's not a question. You're only complimenting on what I'm saying. And this presentation was to sensitize us so that we can narrow down into what we can do at our area. We do what is called disaster mapping. What happens in your area? Which disasters are common? Then we profile. When do they occur? Are they seasonal? Are they, yeah? So with that, you can now prepare and mitigate in a big or a small way, like what the Honorable Member is talking about. Tree planting is very important. And when members go to these COPs, every country commit, I'll plant 15 billion in 5 years or 10 years. I'll plant so much. But again, planting and taking care of it are two different things. And then You can plant, and behind there you are destroying what was planted earlier. So it requires policies and legislative measures in order to achieve that. So I think GACOPA, we can incorporate that as part of sensitization in the many meetings that you go.
Thank you so much, Dr. for the good presentation. I'm concerned about electronic wastes. In your study, how are we disposing electronic waste, even at home and even in the hospitals? Because we don't have a biohazard container that usually carry electronic waste. When we have broken phones at home, do we have a way that we are supposed to manage that waste? Thank you.
Thank you very much. That may be beyond the scope of this presentation. I was handling health sector. However, it's very, very important. And I know many countries have guidance on how to dispose of those electronic wastes. In Kenya, NEMA, the National Environment Management Authority, has details on how to dispose of every kind of waste, classified, yeah? From biodegradable generally to non-biodegradable, and then specifically how to dispose of the electronics. Today I woke up and in one of the forums there was a heated debate on how to dispose of asbestos. So these guidelines are there, but then do we adhere? One of the reasons why we don't adhere to this is that there are no people who are trained technically. We take disasters just general and common sense. I'll do this when it occurs. But there's a lot of technical issues that goes into it. So the first thing is empowering as many people as possible with disaster management skills, and then legislative measures in all the countries.
It's an addition, not a question. You talked about environmental waste, and we are more concerned on the environment, but I will be, in particular, I work in theater as an anesthetist. You find that most of these theaters do not have the scavenging system to exit all the gases, including the nitrous oxide and the halogenated volatile anesthetic agents. And this one can even affect the health workers working in the operating room. So I think going forward, in as much as we are more on the disposable waste which originated from the duties and the functions of the theater, it is also important to look into this scavenging system, because most of these anesthetists operating rooms do not have good, some even do not have scavenging system. And also, it is bad and also can affect the health status of this anesthetist and also the surgeons and everybody working in theater. Thank you.
Thank you for that input.
Thank you. Just in response to the question raised by Honorable, the Chair of the Health Committee, what the association, the union, and the council is doing in relation to environmental conservation. Let me talk on behalf of the council, but the rest can talk on their behalf. We are really greatly participating in matters of tree planting, and it is even in our performance contract. I wish, given opportunity, we would have even shown the pictorial where we have participated last year but one, and this year we are in West Pokot as a council, the chair of the council and myself and the other board members or the council members who are there. Therefore, we are fully in it. Thank you.
Thank you very much.
Thank you very much. I think that's all for Dr. David. Kindly put your hands together for him. Let's appreciate him. He touched on a very important topic. Yes. Thank you, Dr. David. Okay, so before we invite Dr. Fred Mavizi, I need to do these very important introductions. Yes. So yesterday we were joined by two important people. First of which is Dr. Ibrahim Wako Boru. He has a work experience of 34 years in various capacities, 15 years in leadership position. He is currently the CEO or Registrar of Clinical Officers Council of Kenya. He has a master's degree in public health, a master's degree in health system management, BSc in community health development, HND lung and skin. He is currently finalizing his PhD in community health and development. Ladies and gentlemen, let's welcome Dr. Ibrahim Wako. Doctor, please, can you be on your feet so we appreciate you better? Can you be on your feet so we appreciate you better? Yes, that's Dr. Ibrahim Wako. So he's going to give us a short keynote address for about 3 minutes.
Thank you very much. Good morning, colleagues. I'm not going to have any slide presentation. First, let me take this opportunity to thank all of you who have traveled from various countries to participate in this GACOPA event in this country. My single and pleasure is to have with us today the chair of the Health Committee of National Assembly Kenya with us. It is a great honor, and we really appreciate your presence. From the very beginning, that is, it traveled all the way on Sunday and is with us all through in this session. Secondly, it is also my humble pleasure and honor to have other members of County Assembly who are here from Kenya and who are also part of this community of clinical medicine. The leadership of GACOPA, Austin and his team, will really feel your presence and your active organization in this activity. And lastly, leadership of various union associations and the government officials. We recognize all of you. My apology and that of the chair, Professor Kangeta, we are not able to join you from the very beginning due to exigencies of services. We were called to have a meeting with the new cabinet secretary of health. Therefore, we give that as a matter of priority because it touches on our jobs. I want briefly to talk about issues pertaining to harmonization. We are all here under various names: clinical officers, physician associate, physician assistant, medical assistant, health officers, and all that. We want a global recognition under one or two names. This definitely takes the dimension of harmonization in terms of our training, our curriculum, duration of training, issues of internship, okay, issues of practice and employment. Right now, I want to give a good example last week. In our own office, and I was with the chair, We had an old man who cried in that office uncontrollably. His daughter was trained in one of these East African countries, who has not, in our own country, has not met the requisite requirement for training diploma in clinical medicine. But his daughter was trained with a C minor in diploma in clinical medicine, who has not met the requisite mean grade and who has not also met the requisite subject clusters. Was trained in clinical medicine, has the diploma in clinical medicine, wanted to be registered in Kenya. We say this girl has not met requisite requirement to be registered, licensed, and practiced in Kenya. This is just one instance. We have several others. So the issue of harmonization is critical to all of us, so that we speak the same language in terms of entry requirements, okay, duration of training, similar curriculum, similar practice, so that ultimately we are all employed across. If you have that in Kenya, go to Botswana, go to Uganda, we have that common thing. Otherwise, we are going to be faced with such kind of situation. Some countries train diploma in clinical medicine for 2 years. We in Kenya train for 3 years, plus 1 year of internship, make 4 years. We are not going to be the same, definitely. So, the language going forward, and this is to all of us, GACOPA, the union, the association, and the regulatory aspect. We must talk issues of harmonization. We must have common thing, common nomenclature, so that either we call it clinical practitioners and physician associate. That would have been my take. But it is a discussion we are going to put all of us. Some countries don't have internship. Right now, quite a number of countries come to Kenya. They want to be trained the 3 years and go for internship. And our ministry is telling us, if they don't have internship in their country, why do you have the foreigners to have internship in Kenya? So please, forget other things. As long as, right now for medical doctors, across East African countries, they have already harmonized their curriculum, their training institution, inspected across East African countries, and the language they are speaking is one and the same. Right now, if we ask all of us who are here, the number of countries which are represented here, we are going to talk different things. I think if Ethiopia, probably if it's represented here, they are calling it health officers in their country. So let's have a common thing. Curriculum. What are the core things? I look at the core curriculum of one of the countries. They are talking more of, you know, the religion, the Bible, you know, something which is not even related to medicine for a whole year. Okay? Instead of coming up with a common thing, the common subject, anatomy, physiology, medicine, surgery, pediatrics, you waste a whole year, okay, in Bible studies. Those are for theologists. Okay? So these other things, and it matters of regulation. I thank the Honorable Health Chair. Kenya is the only country who the clinical officer has self-regulated, which is established under the Act of Parliament. Okay? We have gone a notch higher from last year now. Our council has been categorized as a state corporation, getting funding, getting the funding from the exchequer on top of what we normally charge as fees. Okay? So this is a courtesy of, that is why you have Dr. Pukose, who is the chair of the health committee, has been very significant and in the center in terms of advocating for our issues. From the time we got our act in 1988 and then repealed in 2017. He has walked this journey with us all the way, even in terms of funding from the national COFA. Similarly, what I will advocate for most of the countries, that is the direction we need to go. Self-regulation. Okay? We regulated training. Okay? We regulate registration and licensing and the practice of our people within the scope of their training. Okay. So my brothers and sisters, those of you, when you go back to your countries, let's talk of harmonizing our curriculum. Let's talk of similar or the common entry requirements, so that we will not be faced a situation like which we are experiencing right now. Duration of training for diploma, and bring in the aspect of the internship, where after you are trained, you will work under senior doctors and senior clinicians. With that, I thank you all of you who have participated in this conference. We are humbled and we are greatly, honored. I thank you. Thank you for participating and thank you for listening. Thanks so much.
Thank you very much, sir. Please, a round of applause for him. He has touched on a very important subject. I'll now introduce Professor Simon Kangethe. He's, 50 plus years work experience from 1973 to 2024. About about 3/4 of us were not born yet when he started. He has a postdoctoral degree from Harvard University, USA. He has a PhD from Boston University. He has an MSc from Boston University, bachelor's degree in medical education, University of Alberta, Canada, HND clinical medicine, ophthalmology. Currently, he's a professor, School of Medicine, Moi University, Eldoret, Kenya. Let's put our hands together and welcome Professor Simon Kangethe. Please, please.
Thank you. Good morning, ladies and gentlemen. It's a great pleasure for me to be here. I wish I was here right from the first day, but I was following you on YouTube. And I could see modern technology has made everything very easy for us. Let me thank the president of GACOPA. Let me thank the Honorable Pukose from Kenya, the chairman of the health committee, who has been holding our hand as clinical officer in Kenya for many years. He's the person behind the approval and the development and eventual acceptance of our Clinical Officers Act in Kenya. We are self-regulating because of this man. Let's give a better clap for him. Without him, it could have been very, very difficult for us to stand. Let me also thank Botswana as a country, as a people, for welcoming us here in this place you call Gaborone or Gaborone? Gaborone. Ladies and gentlemen, my 2 minutes, 3 minute speech is aimed at only one thing. Clinical officers, please advance. Please move forward. Get rewarded for the very difficult work you do. In my very generous introduction, I think I'll be getting you to read my introduction in future. That was a very generous introduction. I've been a clinical officer for 50 years. That's a long time. I've worked in very difficult situations, in very nice situations, but all I know is that we do very, very difficult work. But I think we don't get rewarded for the work we do. Do you agree? Let me say that one of the most important ways for you to advance is to do something that Kenya is trying to do right now. For the last 6 years, I have been trying to force clinical officers to publish a journal called Clinical Medicine Journal. In that journal, you will be able to publish your researches. Do you see the researches that have been shown here? Do you see the research by Njero that he just presented? Okay. Did you listen to the research by Pamela? Did you listen to that? How powerful. And also how beautifully presented. That's the way it should be done. Do you remember the research presented yesterday afternoon by Anne? Was that Anne? Pauline? In the afternoon? Gosh, you are presenting fantastic research. Also beautifully presented. Or I say beautifully because they were ladies. These researches belong not in that booklet you have there. They belong in the CliniMed Journal, internationally refereed journals. When your work goes into internationally refereed journals, when you apply for promotions, you'll be getting promotions the way I've been getting them myself. I have pushed the agenda of clinical officers publishing their work in internationally refereed journals since the year 2015, 2016, 2017. You are not doing it. I don't know what you are scared of. But maybe that is good for me, because if you don't publish, you will not become professors. And therefore, you can't compete with me. But the better side would be that you do publish your work in internationally refereed journals so that you move up, like doctors, dentists, pharmacists, and nurses. They have their own journals. That's how they publish, and that's how they get promoted. I tell you, without Mr. Njero, please stand up. Let these people see you nicely. This is a short man like me. Sometimes it's difficult to notice. This man joined at my request the effort to publish the CliniMed Journal just about 2-3 months ago. And this journal, which had completely died, he tried to revive it. It's on its feet again. Journal, thank you very much, Njero, for that effort. I want all of you from Botswana, those of you who are from Rwanda, those of you from Uganda, write to the Secretary General of Clinical Officer Association in Kenya. Tell him to publish that journal quickly. The articles are there. The pharmaceutical companies which want to advertise in it are there. I have already identified for you the international reviewers from the United States, from Tanzania, and from Kenya. They are waiting. What is the association in Kenya waiting for? Publish that journal. Begin to put this beautiful work into the journal. Are we together? That is the way you'll move forward. In academia, in our professional work in health, we advance through research. Research are the legs that move our communities forward. Publish or, let us say that together, publish or perish. Everybody knows that. You clinical officers, or do you want to be called medical assistants? No. Or do you want to be called clinical practitioners? Or do you want to be called physician associate? You travel and have 1,000 names. That's why you get no credit. Begin to harmonize. As the executive officer of the Clinical Officer Council, Mr. Ibrahim Wako has told you. The boat to harmonize began in Rwanda 2 years or 3 years ago. Was it 2 years? 4 years ago. Just last year, we came to Rwanda and we agreed we are going to harmonize. But that process has stalled down. Why don't you want to harmonize? Please harmonize so that you'll be traveling by the same names. Wherever you go, people will recognize you. My emphasis in my presentation today was clinical officers, please advance and get rewarded for the work you do. For me, I have been rewarded already, but you hear for how long I've been working at this? Do you want to wait for 50 years to be rewarded? You want to be rewarded now. And the only way you get rewarded is by making sure you publish. The other thing I want you to do is that all of you sitting here are gifted in some way. Please move up and start taking advantage of opportunities that are given to you. Those who have done a diploma, move to degree and specialize in the degree of your preference. Some of you are needed in our universities to teach clinical officers anatomy, physiology, to teach immunology, to teach parasitology, to teach medical microbiology. And as you are doing your studies, you know the areas in which you are interested. Move up to degree level, move up to the bachelor's degree, master's degree. I have gone a long way because I was very interested and I was enjoying myself. Choose an area in which you are interested and move up. Remember one other thing, clinical officers. Although you do very, very important work, not everybody likes you. No, not everybody. You are doing fantastic work, but not everybody likes you. Even I don't like you. The faster you move up, you become a competition to me. I encouraged a clinical officer more than 20 years ago to go and do a higher diploma. Then I encouraged him to do a bachelor's degree. I also encouraged him to do a master's degree. Later on, he came and he actually finished a PhD. Do you know where he is now? He's the deputy chairman of the Clinical Officers Council. Do you know who the chairman is? Myself. He's the deputy chair. Do you know what that means for me? Do you know what that means for my job? I'm in great danger. I don't like you. I only have to agree with you and work with you because I'm very lonely up here. I need company, but I don't want you too close so that you are likely to take over my job. Thank you very much.
That was great. Please, let's do it for Prof. Let's do it better. Let's do it better. Wow. Thank you very much, Prof. Simon Kangethe. It's 11 a.m. A little bird has whispered that breakfast is getting cold. So we'll have breakfast. Please, 20 minutes for breakfast, please. I don't want to be coming around to be calling anyone to sit. 20 minutes for breakfast. When we are done, we reconvene quietly. Then Dr. Mavisi will have a speech. Then the Vice President of GACOPA will have his presentation. Then we move to the leadership. The President for the Indian PA Association will have her speech online. Then after that, we move to the symposium. Okay, to the symposium. So please, We are breaking for breakfast now. We reconvene in 20 minutes. Thank you.
So before we go, we were having a little discussion in a WhatsApp group about a discussion about NCDs. And there were about 5 of us. We agreed that maybe we can meet during the breaks we have. So the first break is the tea break. I wanted us to just get to know each other and see when we can actually discuss. So I have Lucy, Margaret, Sylvester, and Evans. Evans, I didn't get your number because you're not using that name as a username for WhatsApp. So if you are here, Evans, and the rest I've mentioned, let's just remain for a minute or two before we get to the break. Thank you.
Okay, thank you. So the names? The names he mentioned, kindly wait behind. The rest of us, breakfast. Thank you.
Danganya hapa. Tumekle. Francis. Can I have one here, please? As if I am presenting. Maybe I am chocha for photos. Oh, we should take one for the group. Oh, asema just nyingine zero. Light iko haiko sawa. Oh.
can see me here. Okay. How's it? Or I use this mic? It's good.
Hello? Please, let's come in and let's...
You lost.
Do they have your slides ready? Okay. Can we all get seated so we start the second session? Those in the tea room, please get back here. I can see people standing and chatting. They are done. Oh, okay, that's fine. We'll still continue whether they get in or not. Yes. At this point, we'll call on Dr. Fred Mavisi. He's a consultant pharmacologist and infectious disease specialist. He's the chair for the health committee of Vihiga County. He's a lecturer in pharmacology and tropical medicine. Ladies and gentlemen, let's put our hands together for Dr. Fred Mavisi. Hello, hello.
Thank you so much. You know, the first time I saw him in the morning, I thought he was dressed in a dress top. So, that was the first culture shock I had this morning. Eh? But I think Kenyans, when you see me dressed like him in the streets of Nairobi, don't confuse it to be a dress top, but it's something that I borrowed from him. You look great. Thank you, thank you. Actually, I wanted to present this when the chair of the Health Committee, the National Assembly, is among us. But nevertheless, I think I'll just continue because the presentation touches mainly on the budgetary allocations we get as counties from the national government in the Republic of Kenya. A few presentations, slides on public-private partnership in enhancing efficient healthcare delivery systems. I am a consultant pharmacologist and a specialist in infectious diseases. And I've taught at the university for almost 10 years now in the field of pharmacology and tropical medicine. Also have some background, postgraduate training in health system strengthening, just like Dr. Wako from Harvard University. And I believe as Africa, thank you, Chair, Africa healthcare systems are not functional as per the rallying call of WHO and the UN SDG goals of a proper healthcare system. And if you look at those 6 components of an efficient healthcare system, that's from the patient, healthcare, human resource for health, facilities and equipment, healthcare supplies, the processes, and partnerships. Kenya had a very good program that were meant to be borrowed by fellow African states. And I believe I talked to the chair of the National Assembly on Health about it, the MES program, the Managed Equipment Services program, that was meant to revolutionize how we manage our patients in the country. But at some point, the mess became a mess in the long run. So how do we go about it as a country, now that other African states were looking up to us to borrow from whatever we had implemented in 2017 to 2022 5-year budget cycle. And I'll speak about my county, that is Vihiga County, where I chair as the health committee. Budgets for health, someone talked about the budget declaration of 15%. They are a drop in the ocean. In my county, we budget for around 1.7 billion out of the probable shared revenue we get from the exchequer of around 6.5 billion. And out of the 1.7 billion, almost 1.4 billion goes towards recurrent expenditure, and that is human resource for health. So you end up remaining with around 200 million Kenya shillings to do the other aspects. You need supplies, you need to equip. This healthcare workforce needs promotions, you need to recruit more healthcare workforce, and many other that may come along. Those you find each and every time, Kenya particularly, we have the strikes, and we have patients as politicians ourselves who come to us and they'll be telling us there are no drugs in hospitals, there are no officers in hospitals to attend to us. So how do we go about it? PPP model, which was very well articulated in the last regime, but we lost it along the way. I stand as a politician, and I would say in the mind of politicians, there are 3 things that we look at. One is groundbreaking. 2, grand opening. And finally, a funeral for a key personality. These are 3 events that will give you free crowds as a politician. And in budgeting, it is very hard as a chair of the health committee to convince fellow members to push for budgetary allocations towards either human resource or even HPTs, health products and technologies. Why? Politicians are fond of brick and mortar. A politician will easily lobby for any project that will be built, and he will be pointing at that project in the long run and saying, I did this for my people. But how do you convince them that indeed we need an extra clinic officer, we need an extra surgeon, we need extra medications to these facilities? To them, that is a passing cloud. And I will laud the county of Kilifi, Kakamega, for having chosen members with the health background to lead their committees and into their local assemblies. Our very own parliament, we are lucky as a county, as a country, to be having a healthcare provider in Dr. Pukose chairing the health committee. And that is why you see most reforms happening at the national government. It's because of him. And we are replicating the same in the county that we come from to ensure that we have enough resources going towards health, just like we have enough resources going towards transport and infrastructure, where mainly most of our colleagues in our local assemblies and even the national government look up to how many roads will be tarmacked, how many roads will be opened, and how many roads will be maintained. So it's a rallying call as stakeholders in health. Now that we have stringent budgets as a continent to go the PPP way, we have roads in this continent that are being funded by World Bank and other development partners. We have water projects that are being funded by World Bank and other development partners. But how many infrastructural improvement do we have in health that are being funded by World Bank, African Development Bank, and other partners? And this essentially is the brain of an efficient working political system. So ladies and gentlemen, let's look at the public-private partnership in enhancing an efficient healthcare delivery system. So according to WHO, there are 6 key components of an efficient healthcare system. One is leadership and governance, service delivery, health system financing, health workforce, HPTs, that's the medical products, vaccines, and technologies, and finally, health information systems. Kenya, we are lucky in leadership and governance. We have members who sit on those committees, and we have a vibrant union, both for clinical officers, the nursing union, as well as the KMPDU, who advocate for the best practices that would enhance healthcare delivery to the common mwananchi, as we call it in Kenya. And it is pertinent upon us as stakeholders. The first component, the leadership and governance component, is very critical with regards to budgeting for health and pushing for these partnerships in different forums and different fora. If you have leadership that will drive the agenda towards a particular budget item in a fiscal year, it will go a long way in allocating resources towards given components of healthcare system that will enhance delivery in the long run. Service delivery. How well is the system delivering the required services to the common mwananchi down there? And currently in the global community, the rallying call is PHC, primary health care. And I'm calling upon clinicians here. We've left that to the nursing officers. When I was elected, I was shocked when I walked into one of the facilities and I found the in charge of the facility was a diploma holder in nursing, and we have a BSc clinical medicine sitting in the outpatient department. Is it really right? Is it right? We go back to the first aspect, leadership and governance. What did I do? I started the conversation of amending our local Health Services Act to give the requisite minimum threshold for one to be a facility in charge. It doesn't augur well to have a BSc clinical medicine at the outpatient being instructed by a diploma nursing officer. Goes back to the first aspect, leadership and governance. Health workforce. In my home county, we advertised for 36 positions of nursing officers against 4 positions of clinical officers. 36 against 4. Washira, are you okay as a county? We are not. This will hinder health service delivery in the sense that in Kenya, we know very well, most of the OPCs are run by clinical officers. And in the same facilities, you'll find we cannot even handle NCDs because the capabilities of the nursing officers in handling NCDs is limited. So these patients are forced to walk long distances to go and seek care. Yet, the nearest facility, the persons handling those facilities are the nursing officers. HPTs, medical products, vaccines, and technologies. Same problem we have in Kenya and Africa as a continent. In Kenya, I'll give an example. We have 2 main suppliers, which the government, and Dr. Pokos, I think you'll have to come in and help us in this, which the government has prioritized the counties to be buying from, KEMSA and MEDS. And in our budgets as county governments, you'll find we budget for KEMSA, say 100 million, and they will supply commodities, maybe worth 70 million or so. Some they don't have. The governor will come in and flag those products. It will take another 6 months. After we've done a supplementary, for you to get another restock of the HPTs. So why can't we go the PPP way, where the key essential medications that are required to run an efficient healthcare system can easily be obtained from a nearby facility or pharmacy that is well sourced by the county governments or the hospital as per the Public Procurement Disposal Act, what it dictates. HIS, same problem. In my home county, as a committee, we were doing random checks, and we came across like 4 different partners who are funding the county on matters HIS with different systems or softwares to manage HIS. And if you look at KHIS that we have in the country, or even the DHS program that is funded by the USAID, most of the information that is required to draw reference, either with regards to when you want to manage a patient, or you want to plan for that patient, you want to budget for that patient, is missing. Is missing. There was a time the Kenya Bureau of Statistics came to our home county, and I raised that question to them. Because in the statistics, they were giving indicators that are not relevant to our own county. So in Africa, we still have a problem with HIS. And today, yesterday when we visited the parliament, I happened to have bumped into a long-term friend of mine who is working at the AU as a consultant with regards to communication and infrastructure development. I wish he was here today. I asked him, I think he'll come in later. And they have a robust funding model for other departments in Africa with regards to communication technology. But then they have nothing for health. So I wanted him to come here and probably tell us at the AU Commission, what are they having for health with regards to HIS? It's my desire to see diagnosis in Morocco, Malawi, Kenya, and Botswana can be referred or referenced or even consulted by a clinician or a consultant at Nairobi Hospital or Kenyatta National Hospital in Nairobi. So we have a long way to go, so that if we really rely on our national exchequer release for HIS. As I said, globally, we are looking at UHS now. And I'm calling upon the clinicians, please let us grab this the way Professor Kangede talked about. Let us go forward and grab UHS with both hands, run with it, and let us be on the forefront of championing primary health care in our villages where we come from. We are 6 years shy of the 2030 deadlines as outlined by the UN. And developing countries, as you see, they spend over 0.5 trillion US dollars in out-of-pocket expenditure. By 2030, gap will be at around 176 billion US dollars that is needed towards achieving the SDG 2030 in regards to health as far as UHC is concerned. And the key indicators that actually drive towards achieving that particular SDG deadline. One of which was reproductive, maternal, neonatal, child and adolescent health, infectious diseases, NCDs, and service delivery and capacity or access. In my home county, service capacity and access, I think we are way beyond the WHO recommended guidelines, because they say from one facility to the other, we should be doing around 5.3 kilometers. In Viga, we are 2.8. So from one facility to the other in my county, we are at around 2.3 kilometers, 2.8 kilometers. But the WHO recommendation is around 5-point-something kilometers. But then, as a chair of health, I also find it very difficult, because a politician will come to you and tell you, Chair, I want to build a dispensary. Then you ask him, where will he get the manpower and the equipments? And then they'll tell you, this is the only thing I'll show my people, and I promise them during the election cycle that I'll build a dispensary for them. Yet we are at 2.3 kilometers from one facility to the other. Some facilities don't have even enough manpower, they don't have drugs, they're not well equipped. But then they want to do what? To increase the number of dispensaries and health centers in those particular facilities. The other component that is being looked at is the financial protection, where we're looking at, we are judging it about between 10-25% of the budgets of the county. And in Kenya, I'm happy the 3.82 indicator, I think we'll be achieving it the way the chair of the health committee in the National Assembly wants to implement FIF or the SHIF in the long run. I think it will hit into a pocket, but in the long run, I believe the financial protection that we will give to our local population will be immense towards achieving a robust healthcare system delivery. Service coverage, as I said, is country-specific and county-specific for Kenya, but there's a huge gap in NCDs, a huge gap in NCDs. When I was coming here, there's a gentleman, he's a border rider. For those who come from Kenya, in the West, we call them Okada rider, who lost his wife. And he sent me a message and told me, Daktari, if my wife had gone through the second dialysis, I think she should be alive today. She should be alive today. And I'm happy Sylvester presented something on NCDs here. This thing is real. I've done medical camps myself prior to my election and after my election. And the burden of NCDs is real in the villages in Kenya, even across Africa. And it calls for us as clinicians who are here to move forward, as Professor Kangeda said. Let us grab the primary health care component, where most of the funding, you look at the funding that is coming to primary health care, it is huge. It is huge. So let's be on the forefront. Let's manage these patients, their pressures. You understand what it means for these patients to come back to you with high pressures. The brain might be gone, the kidney might be gone, even the heart. So it's upon us to pick it up and bridge this gap. As clinicians, even as politicians, we are lobbying for more funds with our local governments, as well as the national governments, and other development partners. The WHO has given a $3 billion target towards attaining a proper health system and achieving UHC. They say they want 1 billion people to be well covered in UHC, 1 billion emergency protection, and 1 billion having a better health and well-being. Better health and well-being will come along also with the aspect of managing climate change and our nutrition, and even NCDs in the long run. The common models in health, PPP, we can go the financing way, where most counties nowadays are development partners, they go the co-financing way. In Viga, we have a very good component in co-financing between the NCD Alliance Kenya and the Nutrition International. NCD Alliance Kenya have done a very good clinic at Viga County in a place called Amisi. They have done 3 clinics. One is in Viga, the other one is in Isiolo, and I think it should be Wajir, where you have a comprehensive clinic that covers NCDs as well as sickle cell disease. And I think somebody who presented on sickle cell, you can come and visit Viga County. It is well equipped, well equipped. One of the counties where you have one-stop shop for all matters concerning NCDs and sickle cell. Well equipped. Design, you can go inside to do infrastructural development, either through building as number 3, or just do the architectural drawings and final delivery model where you equip and leave the facility to the county. You can do the maintenance. This is where MES was. This is where MES was, but the managed equipment services that the government pumped in close to $400 million US, government of Kenya, towards acquiring machines for renal, ICU, even cardiol. But unfortunately, as I said, along the way, it got messed up. You can decide to operate. You just supply the equipment, operate, agree with the national governments or the county governments on the profit-sharing models, and finally, deliver a model where you deliver and manage the specific clinical and support services. You can decide to pick a given clinical aspect, either cardio, renal unit, the imaging unit, and then you run away with it to the private partner and agree on the shareable revenue that you can share in the long run. Why PPP? Because there is need for quality and efficiency for care in these patients. More so, to achieve quality and efficiency, you need data and proper systems. And this is where we lack again as countries and this continent. Data is critical in both management and budgeting. It is very sad when chief officers come to us to defend their budget before the health committee. Then you find an entry in the budget. Then you ask them, what is this meant for? They tell you, we are project to build a particular unit in this particular area. What drove you towards deciding to build this particular unit in that particular area? Do you have the data to support that? By data, I mean the indicators that show that particular area. Once you build that unit there, it will help those people in that particular area. They go back to their system, the data is not there. So with data, once well captured, it can help in the planning and even budgeting in the long run. Sectors thriving in PPP. I talked about the transport sector, water, energy, etc. And a lot of funding agencies are pumping money into transport and water. A good example is Kenya. We signed an agreement with the US government to build a superhighway from Mombasa to Nairobi. Yet we have the SGR. Was it logical? We have the standard gauge railway, but we signed a multi-billion-dollar investment by a private partner to build a highway from Mombasa to Nairobi. Yet we have a standard gauge railway. So there's opportunities. If we can do it for transport, if we can do it for water and energy, then we can also do it for what? For healthcare. What are some of the working models in partnerships? The specialized services, that is where MES comes in again, imaging, dialysis, cardiol. You can also do the building. Kakamega, I think, Maboka, you are trying to go this way to find a partner who can come in and finish the level 6 hospital, and finally probably work with the county government on how they can share in the long run the revenue. And revenue in health, unfortunately, it is one of the biggest on-source revenue producer in Kenya. Other than Kiambu and Nairobi, all the other counties, they depend on health to get their revenue. all other counties. Go to the Office of the Controller Budget. Most of our own source revenue in most counties in Kenya, they come from health, apart from Nairobi and Kiambu. The other counties, it's health. And I was telling my CCM, the Minister for Health in the county, when they came to defend the budget in the month of June, I was asking him why in the budget they have not allocated any funds for recruitment of more healthcare workforce. And he was telling me the budget is constrained. And I was telling him, Waziri, have you checked our records as far as our own source revenue is concerned? We are the biggest contributor to the county's own source revenue. So you have every right to go to the cabinet and defend and demand and tell the cabinet that I need more healthcare workforce because I produce or I raise more revenue compared to other departments. It doesn't make sense to have a market clerk going in several markets to get revenue, and at the end of the month he's earning around 40,000, but he's able to raise about 20,000 at the end of the month. And we have a healthcare worker here, a clinician, who is able to see 40 patients per day, do the imaging, even do some surgeries, and raise close to 200,000 at the end of the month. So it's prudent enough to pump more money in healthcare because in the long run, the returns are very high. This is a case study that was done in Kenya, the Vision Impact Project. It is a 2.2 billion project that was funded by CBM and other partners. The main goal was to try to mitigate avoidable blindness. And the overall objective was to reduce the prevalence of vision impairment and avoidable blindness in target counties in Kenya by December 2025. So it is actually ending next year, December. And the counties that were being funded was Embu, Meru, Bomet, Vihiga, Kajiado, and Kiambu counties. In Vihiga, this project began in 2021. And by the time I was being elected in 2022, I found there was a lot of politics around this project. And I told the governor, Your Excellency, I think you're losing the big plot here. These are partners who are coming with money. All they need is space to build their own clinic, equip it, and even hire healthcare workforce for you. So why are your officers blocking it? After 1 week, we did the groundbreaking, and we have a clinic that is well equipped in the county with all the machines that are needed for eye care delivery. The result areas was the evidence on the need for eye health, capacity of health facilities, and use of peak technology, community screening, school screening, and governance for eye health. Target population was 5.3 million. That is around 70% of the target 8 million in the 7 counties that are actually benefiting from this particular program. They picked these hospitals. Sabatia Eye Hospital is a private hospital in Vihiga County. Tenwek is a mission hospital in Vihiga County. Kwale Eye Center, it is a private facility again. AIC Health Ministries, Operation EyeSet, is a partner that is helping in funding this program. Fred Hollows is also a partner. And then the PCA Kikuyu Eye Hospital in Kiambu County. So the main goal of this was school screening and community screening. And if you look at it, in the school screening program, the CHPs that are being used through the peak technology, that is at the primary health care level, where they were doing the triage, and they were either referring directly to a tertiary hospital. In the long run, it was either Sabatia Eye Hospital or the Vihiga County Referral Hospital, Kwale Eye Hospital, or even PCA Kikuyu Hospital for those who are in Kiambu. And either secondary hospital, that is a sub-county hospital, or any other facility that is nearby that has an optical shop or an eye unit. And eventually, for those who needed glasses, were given in the referral system that you can see from the diagram there. So the key component here were CHPs who were trained initially together with the healthcare workers who were absorbed in the program, trained by the PIC technology and CBM, Operation Eyesight of Universal, and the Fred Dolos Foundation. The target population was 8 million, as I said, and from the 8 million, they were able to screen around 5.3 million. From the community, it was 60%, and from the school population was around 80%. 576,000 were treated, and we had an amazing 28,000 cataract surgeries. And 43,000 spectacles were given to those who needed spectacles and those who had low vision. We trained over 234 healthcare workers and equipped functional facilities or eye units, around 708. Low vision devices that were dispensed was 1,977. And then model inclusive education schools were 7, and education assessment resource centers equipped were 7. I wish to talk about the model inclusive education schools. These are schools that were selected in the 7 counties, where the program went around and looked at the infrastructural capacities of those classrooms. And if you look at this room, if these lights were switched off, I believe most of you won't be able to see your writing pads or even write. So imagine these students in the rural villages in Africa or Kenya, where there's no electricity. How do they see? From this, I was able to bring up a motion on the floor of the House and compelled the Transport and Infrastructure Department in the county to ensure each and every building in the county had translucent sheets in their roofing to give natural light to these students when they are in school. And to ensure when they are building these classrooms, they ensure that the classroom is lit as much as possible with the natural light. The cost of electricity in most of our schools is very high. And most schools are often disconnected from the main grid because of the bills that emanate from electricity. So the simple model in the 7 counties where one school was remodeled to cater for the needs, optical needs of these students as well as those who are disabled, so that they can be able to be at par with the rest in their classrooms. And the cost was very simple. We were only able to change around 4 sheets on the roof and install translucent sheets that were able to give enough lighting for that classroom to allow the students to visualize very well their books when they are reading. So these are the pictorial evidence that we have as a program from the beginning all the way from the dissemination workshops, the meetups with the governors and the relevant stakeholders. These are the infrastructure development, those CT scans, etc., that were given to those particular counties, and the eye units that were being built. Still, the trainings of CHPs, healthcare workers on PIC technology, on how to do the referrals, etc. Those are the assistive devices and PIC technology going on, sit-down examinations for the patients, for vision devices that are being given, the spectacles, etc., and the school program that is going on. The aspect of the school program, actually, we ensured that each and every school had a health coordinator who was able to be trained on PIC technology, and they were able to screen those students and send real-time the data to the referral system that was built by CBM and the partners in those relevant 7 counties. Still the same on the aspect of governance, etc. I think that is it, ladies and gentlemen. Thank you so much.
Hello. Please, another one for Dr. Fred Mavizi. We'll take 2 questions. First of all, are there any questions? Does anyone have? You have a question? Does anyone have a question? Kindly put your hand up. Any questions for Dr. Mavisi? Scott, don't put your hand up. I won't call you. Anyone else? Scott, do you want to go? Okay. Then looks like you guys understood everything Dr. Mavisi presented. Okay, Doctor, thank you very much for that wonderful presentation. Thank you. At this point, we'll call on Mr. Pana. He's coming to give us a status update on the clinical practice of physician assistants. No. Community health. The names are plenty. You can't keep up, bro. The names are plenty. Let's harmonize and get just like Prof was talking about. So please.
Thank you very much. Is the afternoon now? Good afternoon. Can we please get the presentation from Sierra Leone, please? For a second, I want us all to imagine a situation where you will have to wait 5 years after medical school to send somebody to become a specialist surgeon. A country of 8 million, like Sierra Leone, or a country like Kenya, who has a huge number of people, how long it will take to have sufficient healthcare providers that are able to provide surgical need of the population. Also, I want us to watch and think around the myth that surrounds health, providing of surgical care should always be in a high intensified facility. These are myths that have been going around, and researchers have shown that they are myths, and beyond records, people have been able to contribute significantly towards this. So I'm going to take you through the joining of the contribution of community health officers, clinical officers, otherwise called in other countries, towards access to surgical care in Sierra Leone in the way of having universal health coverage. While we are waiting for the slides, I want to tell you all that the training of surgical officers who initially will have a background as clinical officers with a BSc is an additional 3-year program in which they have a 2 intensive year of training and a 1 year of internship. So it's a total of 3-year program. Even when the slide hasn't come up, so we still have to continue. The IT team. Do we have a problem? It's good? Okay. Thank you very much. Like every other country, Kenya has gone so far with their scope and with the way they've shaped the clinical officers' training. Sierra Leone, like many other countries, we called our clinical officers as community health officers. Initially, it was meant to be medical assistants. Back in 1983, when it was launched, the medical doctors then realized that if you say it's a medical assistance, it will be difficult to deal with this kind of people. And like we said, some of this training were introduced to fit for purpose, but that is no longer the situation. So they redefined it and said it's a community health officers, and so that they can be in the community in the forefront. Forgetting that even in the capital city, forgetting totally the definition of what a community looks like. And today, the Ministry of Health is employing the bulk number of community health officers that have been produced. We have over 2,000 in service, and we have a lot of other people who goes into private practices and also into different administrative, healthcare administrative fields in the NGO. The contribution has been great over the past years, and I really want to show the slides. Is the slide having an issue? Joel? Huh? Yes. So while we are waiting for the slides are very important because we want to show our contributions, and a lot of them are statistical, so that we have evidence-based discussion around the contribution. But I'm yet to tell you that since 1987, that the program was launched, the first batch, it was first higher national diploma program, and over the years, it has evolved, and now it is a bachelor's degree. We still have the higher diploma and the bachelor's degree program. Excluding that, we've been able to move a little bit into anesthesia, ophthalmology, and surgery. These are the three aspects that we've moved into, and some have got added training as well into public health field, especially after the Ebola crisis we have in Sierra Leone. We realized that we had a lot of help from East Africa, and after that, Afrinet was launched into Sierra Leone, and a lot of people are into surveillances and providing public health care. Because the training, like we said earlier on, has got 4 different domains. In Sierra Leone specifically, we are like dealing with 3 of these domains, which is the preventive, promotive, and curative aspect of it. So majority of our friends will not come to the clinic. They will have to be in the preventive areas, while some will have to be in the promotive sectors. All of these sectors are completely employed by the Ministry of Health, while few will be employed by the other private bodies. And as it stands now, okay, thank you very much. We go strictly with the slides. So we are bringing to you the contributions of community health officers, clinical officers through the surgical training program in achieving universal health coverage. We are looking through this with the lens of global surgery. So specifically, we'll be tailoring this discussion to that. This will be the outline that we'll be watching through. Like every other country, we've also got our challenges, and we have a direction for how some of these things will go through. So before going into the slides, let me just give you a background of the global surgery landscape. Back in the days when the world was discussing a lot of issues related to public health practices and how they could salvage global issues, a lot of concentration was not given to surgery. A lot of concentration was not given to surgery until such a time when people realized that Huge number of our population in the community needed surgical care, and this could also be evolved into the public health sectors. And global surgery was born as at then. It is an area that seeks to improve the healthcare outcome, health equity, especially for underserved population and people in crisis. The first time this was discussed was in 1980 by Dr. Harvard Meller, who was then the Director General of WHO. He was addressing global health leaders in which he was begging them that there is a lot of injustice that is going on around providing access to surgical care, and he was urging them that they should give greater concentration to this particular aspect when they're dealing with global health delivery. Since 1980, it was only in 2008, after the late Dr. Paul Farmer and a one-time World Bank President, Jim King, in their article, "Surgery has been the neglected stepchild of global surgery," that this global surgery itself starts to evolve. However, some other countries have been doing other things. Countries like Ethiopia, they were doing other things because the nation realizes what they want, and we are doing things related to that. When Jim King became the then president of the World Bank, because of the discussion they had earlier on, since 2018, people have been working around, but there was like not a good roadmap as to really what guides the practices surrounding global surgery. In 2014 to 2015, they launched the Lancet Commission on Global Surgery. And in 2015, the WHO Resolution 6815 was passed, which give the political strength for government and bodies to give more emphasis on strengthening surgical care, surgical and anesthetic care around the world. This act was what a lot of other organizations or a lot of other body was using to pressure government to see how they can put much more emphasis on the availability of surgical care for underserved population. From the Lancet Commission, 5 key messages were that they brought forward that could be used for every argument when we are coming towards global surgery is that 5 billion people lack access to safe and affordable surgical care. 143 million additional surgeries are needed, especially in LMICs. Investing in surgery that initially people thought was not a possibility, they said it was affordable and it is economical and it can promote economic growth. Once you invest in it, people who, for example, somebody who is an Okada rider in my country, get a fracture and he is able to be reinstated back into the society, he is being productive and he will continue to the economic growth. Additionally, 3 million people face catastrophic expenditure, especially when they wanted to access surgical care. A person from Francistown, for example, having an accident and could only come to Gaborone for surgical care will definitely face this catastrophic expenditure. And the last message on the Lancet Commission was that surgery is an indivisible component of every healthcare system. It is the stitches which we knot all the other branches, starting from cardiovascular diseases, NCDs, for example, tuberculosis. When they do progress to some stage, they get like you need to have pleural effusion, you need to tap some of these cases. These are all surgical procedures. So surgery is an indispensable component of healthcare system. There has been several myths related to surgery, one of which was it's too expensive. So meaning politicians and stakeholders who discuss healthcare system, we are refusing to go around surgical discussion because they feel it was too expensive. But among these myths, the other two that was outstanding is It should only be provided in highly technical facilities, which is a myth because you do not need a very high technical facility to provide wound care for somebody. That is part of surgery. And that it should only be provided by people who are highly trained. This was a myth because clinical officers some of the myths that surround surgery that initially global stakeholders did not want to have discussion around this aspect. WHO and other organizations thought it was that the healthcare workforce wasn't matching the growing population in the world, and tax shifting was introduced. It was introduced with the concept that to increase the healthcare workforce across all levels. It is a system where certain tasks are dedicated to healthcare providers who are adequately trained that can provide these healthcare services. There has been different approaches, all aligned with local health need and capacity building. Countries will have to adopt theirs, and there are dynamics of this healthcare workforce. However, motivating them at all levels, ensuring that those who this work has been transferred to, for example, if you're a clinical officer and you're given a training in anesthesia, how do we motivate them so that they can stay in practices? It's a dynamic thing, and it's challenging for some countries. Specifically had an unmet need of surgical care of 92% around 2010 coming to 2011. And in 2010, we launched the Free Healthcare Initiative for maternal and child health care, for child health care up to 5 years and maternity care up till post-delivery. As at then, we had 92% surgical unmet need. And this was more prominent in the rural area because we all know in almost every country, the majority of the specialists are surrounded in the capital city. So an organization called GACOPA, which is a Norwegian organization, in partnership with the Ministry of Health, started the surgical training for community health officers, otherwise known as clinical officers, and junior doctors. But like we all know, the myth surrounding combining these two categories, initially it was only the community health officer who took this opportunity because they've seen first-hand experience where you need a mother who you've watched in your facility had obstructed labor, could be transferred on a very difficult road for 5 hours only to lose the baby at the end of the day. With this in mind, GACOPA launched this program and started absorbing community health officers for the training. Like I said, it is a year training program. What has been the contribution so far? You see the statistic from 2012, when we started having the first, it started in 2011. From 2012, when like a baseline data, you realize that for this publication, we're using you realize that the public facilities, we are providing like 76.4%, no, 46% of providers. We've used the definition of surgical providers, anyone who handles the knife. So as at 2012, you see it was 46.4%. When training was introduced, clinical officers were absorbed into the training and they started producing clinical officers. It does grow from 46% to 49.2%, And in 2023, you see that the number of people who handle surgical care provision is around 63%. That's a significant change over the period of time. And if you watch the individual cadres that have contributed to this, was we wanted to show the contribution clinical officers have contributed towards having universal health coverage. You realize is that for the specialist surgical specialist surgeons, it's been like from 36.5%. There was a little bit of decrease around 2017, which could possibly due to migrations and other things. And you see, as of 2023, it was around 30%. For associate clinicians, you realize that as of 2012, we had like 8.4%. And that has grown from 8.4% to 21%. And as at now, it is 36.1%. Meaning clinical officers are contributing significantly to the delivery of healthcare services in Sierra Leone in all aspects, including surgery, which tend to be a myth initially. These are the figures. When it comes to service delivery, we see that from 2012 to 2023, there has been significant changes, specifically in the government facilities. Initially, the non-profit organizations like MSF, there's Masanga, there are other hospitals, they were contributing to the bulk of surgical provision because the majority of specialists or providers were people coming from different countries to help the situation. But you see, from 2012, that has been changing. As at 2023, the government facilities, we are proud to say, is accounting for 60.5% of surgical services in the country. And of these services, the majority is around obstetric and general surgery, obstetric in the red and general surgery. These are the majority of services that are provided. And these services, if you watch the workforce volume, you realize that the western area, that's the big town, account for like 21.2%. 78.8% of the country's population are in rural area. And these are the very area where clinical officers are. These are the very area where clinical officers are very willing to work. These are the very areas that needed the services because they have the majority of underserved populations. So if you watch the graph, you see that for the specialists, they have all the time been concentrated around the capitals. And you see, it has been like that. Even as at 2023, you realize that the bulk of the services in the capitals are specialist providers. So should we wait not having other people who can step in to give some of these services for the 78.8%? Is that a big thing to ask as clinical officers that we should be able to serve our population? I don't feel so. And you can see that we are contributing significantly to the provision of surgical services in our country. You see the changes that has been there. Associate clinicians have moved from 12.5, providing like 58.5% of all these operations in government facilities. How does this interplay with global surgery? Both tax shifting and global surgery seeks towards improving access to surgical care, particularly in LMICs. Both are promoting equity accessibility. It should not be only in the capital city for those that can afford. It should also be provided to people who are citizens of that country, who are citizens of the globe. They should have access to affordable and safe surgery. However, also addresses the challenges, the complexity of surgical care delivery, including infrastructure and training. That is why we said global surgery is a land space, it's a virgin area where clinical officers as well can contribute in terms of research, service delivery. They can also contribute a lot to that. However, it should be guided by ethics for Sierra Leone as well. Who considered this, because if we are serving people, we should be able to ensure that we give them the best of care that is of good ethics. Because you and I can become the patient the next day. So if there are no ethical consideration or quality assurance in surgical tax shifting or in every healthcare system, then it becomes very, very difficult. There should also be a evaluation metrics. We should be able to see how we evaluate things. We cannot be saying clinical officers should not do this, clinical officers cannot be dermatologists, and we just say it should be scientific. The world is moving scientifically and should be evidence-based. Yes, with all this, it helps to shape our protocols. So in Sierra Leone, we have got several papers from GACOPA and other bodies, including to assess how is the tax shifting going on. One of such a paper was comparing the cesarean section done by associate clinicians and those done by doctors. And you realize that, in conclusion, the paper was saying that cesarean section done by associate clinician or community health officer are not inferior to that done by specialists or medical doctors. And this was a longitudinal study because they had to do it over a period of time to come with several papers. One of the papers was this. And this paper also includes Sierra Leoneans. It was not only foreigners, it includes Sierra Leonean surgeons who contributed to this paper. Another paper also was looking at the learning curve for cesarean section, and they also found out that when you train clinical officers, several surgeries, they get improved, and the duration of their cases, it decreases. People might start with an hour. Over a period of time, it decreases. And we know for surgery, the longer you stay, the more you expose the patient to a lot of other things that you cannot account for in the theater, including the anesthetic effect. So this is all telling us that while we are doing any of these tax shifting programs, or we are doing any of these things related to community health, to clinical officers, in relation to specialty, in relation to our practices, scientifically, we're able to see how we can prove beyond reasonable doubt that what we are doing is measurable and we can be Had we had this all in Sierra Leone without challenges? No. Like many other countries, we have our own challenges. One, the regulatory framework. Sometimes it's very difficult. They want you to work under supervision, and they will say it can be direct or indirect supervision. But you are faced with a lot of challenges that with this autonomous body who can regulate, where we can regulate ourselves. Sierra Leone has pushed for that, and we are very close to success. Also, the acceptance from senior people. A lot of other healthcare providers find it difficult to see how clinical officers can provide some of these services. Also, motivation and retention. You cannot train somebody with high skill as a dermatologist. They've gone all through this, and we do not motivate and give them good retention package. They cannot stay in those facilities for quite a long time. Meaning, these are some of the challenges and more we face in Sierra Leone as well. What are the way forward? It should be a multidisciplinary effort at all levels. We should be able to have everyone contributing to ensure that clinical officers continue to provide healthcare services for their people at different levels. We cannot be limited just to one level. Also, we need partnership, like the partnership we have now with GACOPA, having partnership with East African communities, have partnership with IEPA. These are the partnerships we looked for so that we can improve on the capacity building. Where we are lacking, we should be able to contact His Excellency President Austin, and that Sierra Leone is in this. How do you help us to this? We want to front our our policymakers. How do we go about this? Infrastructural development. In as much as we want to provide all of these, we should be able to contribute significantly to the infrastructural development. The facilities we have, we should be able to take good care of them and see how projects can be evolved so that they can be better. Also, advocacy. If we do not tell our story, people will tell our story for us, and if they tell our story, they will give the wrong narrative. As clinical officers, as community health officers, whatever we do, like Professor was saying, we have to push beyond boundaries to make sure that we start writing, we start publishing what we are doing. Because if we did not tell our story, people will narrate our story for us. And trust me, they will do it in their language. Also, we have this collaboration. In all of this, finance is possible. So once as healthcare provider, as clinical officers, the one thing I have learned is if we are talking to professionals, like like doctor was presenting recently, if you talk to policymakers, trust me, they all think around money. But if you show them the way that there's money there, we can use that money. We are providing the money as healthcare provider, we should be able to use them. If we want to set up clinics in certain areas, we can tell them that there is insurance money paid by all taxi drivers, by cab riders. We should have some of this money to establish a system where if they have fracture, we should be able to take care of them. Once we give them these innovative approaches, then they tend to listen to us. It is not that they don't want to listen, but the money is a big problem. In conclusion, from Sierra Leone, clinical officers, community health officers, associate clinicians, we do believe, and the world do believe, with an open heart, that we can contribute significantly to safe and affordable surgical care and anesthesia care in order to achieve universal health coverage. Also, tax shifting is not meant to replace anybody or take a job from any person. We are there to contribute, to augment the existing healthcare workforce, because we cannot allow our 78.8% of people going without access to care until then, when we don't know when we are going to have enough surgeons to provide. Countries should embrace these healthcare professionals like Kenya is doing. We ask other countries, including Botswana, and specifically, to embrace these healthcare providers and arrange a smooth pathway for upward growth, because nobody wants to stay in one place forever. These are the challenges we face, and if countries are able to, this enabling environment that people are able to transition, it gives a better way, and our practices can be of good to the people. Thank you very much from Sierra Leone.
Okay, thank you very much. Sawa. Hey, okay. Please, do you have any questions for Mr. Tairu Fofana? Any questions? We are taking just 2 questions. Any questions for him? As usual, Scott.
Thank you, moderator. Thank you so much. Thank you, colleague. I'm so tremendously impressed, Taru, what you have done. And this research is so important. And the impact that you're showing with the research numbers is what we need. You know, we were talking earlier with Prof. Simon about the research and the publications that we need. And this work is done. And I know other colleagues have done this work, and other colleagues are seeing this work and seeing the impact. So we just need to take time to document and research. And I really appreciate your bringing us through this story of the global surgery. Global surgery has become very popular. It's become very important. The university where I am, we have a global surgery department. We're trying to work with Southern Africa and all of our colleagues there to promote this. I mean, and the myths that you bust, that's so important. Surgery is not as complicated as it appears. Surgery can be trained. Surgery is not as expensive as it appears. It can be done. It can be done in low resource settings. It can be done in other places than the hospital. I mean, certainly there's so much that we can do as clinical practitioners to improve this. So I really thank you for bringing this. I want to extend an invitation for you to come to IAPA conference in Virginia. I would like you to present this to our colleagues there. You know, our colleagues, many of the colleagues will be from the North American continent, of course. It's more accessible there. You know, IAPAE every 5 years travels to the different 5 geographic regions with our conference in order to collect those in that area. So we're returning to North America, and many of our North American colleagues, our PAs there, are very interested in global surgery, are very interested in connecting. This is a way for us to show, you know, internationally what we do. So I really hope that you can attend and be there with us and present. Congratulations.
Thank you.
Thank you very much again for that presentation. But as I said earlier, this is high quality presentation. If you remember the one by Pamela earlier today, the one by Pauline, I don't know why I was calling Pauline Anne. I have to investigate my previous association with Anne's. And please, all of you are saying references. References at the end of your work. Please say references and bibliography. You understand why? Because when I look at some of this work, I can see where you are quoting the references. What is in the text that is in reference. But there are certain areas where you don't see the reference in the text. You must add bibliography to cover yourself, to say, I have got this information from some book I read, but I don't remember the exact details of the book. But you say references and bibliography. That way, we can transfer this piece of work directly into the internationally refereed journals. And these journals will earn you points. But I told you, I want you to publish so that you can advance and get credit for what you are doing. But at the same time, I don't want you to publish too much because you are likely to overtake me in the work that I am.
Thank you.
Yeah. I think I'm the least person to comment on this research, since I'm the least person to be reviewing journals. Yeah, I have professors here, so I'll keep my mute. I think with what maybe Leonard colleague was saying, when we use Mendeley or Zotero, these things can be collected very well, especially Zotero. I don't know which one you are using, but with Zotero, you are using Mendeley. All right. My question was, I always go with health system. So my question was, you mentioned something that leads to, with healthcare financing, let me give you a background so that we come back. Healthcare financing, you realize that when it depends on the co-sharing of the person, you can go to that page if you are there. You see that it depends on the funding you are taking from, whether it is the patient who is funding the whole access of the healthcare. If it is the patient, then we can talk of the costs leading to catastrophic costs and leading the patient to become impoverished. So those two things, but you highlighted only one thing that leads for the cost to become, for the patient to become, the cost to become catastrophic to the patient, and you highlighted that the patient has to travel. Is that correct?
I was just giving an example of how a patient who will be, for example, in Francistown, need to come and seek healthcare services in surgical services in Gaborone,
Yeah.
for example. In my country, it's not free for you and I, except for women. It's not free. So the cost
So
involved.
it is not the access to the healthcare, but rather it is the cost to access the healthcare.
So this can be put in two ways. We have direct and indirect cost. And anything around 10% of your income is above 10% is considered catastrophic.
So,
but however, there are different measures people use to determine which one is catastrophic or not. Initially, people were not taking into consideration those insensible costs. For example, transportation, you come to the big city, housing, feeding, they were not taking care of that. And people were not even considering that if I am going for surgery, I have to be 2 weeks unproductive. We are not calculating all these things. So for every process, you have to set the definition. It can be direct cost and indirect cost that will lead you to catastrophic expenditure. And my country is among the countries that gives high catastrophic expenditure as a result of healthcare services.
Like I said, I'm impressed with the research, but this one can go straightly to PubMed. So we highlight those things so that if there is a peer reviewer, if there is a general reviewer, he understands what you are really saying by the patient having catastrophic cost. Thank you.
Sawa.
Great work.
Any other question? Okay. Mr. Tairu, thank you very much. Please, let's put our hands together for him. Let's put our hands together for Mr. Tairu. And we'll do this small exercise. Everyone be on your feet, please. Respectfully, everyone be on your feet. People are sleeping. Everyone on your feet, on your feet. Everyone be on your feet. Everybody, everybody. Every Malita on your feet. Everybody. Yes. We are going to spell GACOPA with our waist. Yes, we are going to spell GACOPA with our waist. So G. Then we come to A. So we are coming to start. Everybody. Okay? By which time those who are sleeping will not sleep again. Let's go. GACOPA G. Let's go with our waist. G. Yes. Capital letters. So A. Let's go. A. C. O. Malita. P. Good. This girl is not. I'm come this way. She's not doing it. You. Then the last A. We spelled what? We spelled what? Put your hands together for yourselves, people. Yes. So we cannot have our seats. Before we leave here, we spell Botswana with our waist. So prepare. Okay, so this next presenter and this next topic is a very important one. It's been one of the reasons why we gathered here. The Vice President of the Global Association of Clinical Officers and Physician Associates, Dr. Antonia Asare-Akon, is going to present on the global strategic impact that GACOPA has outlined. We took a lot of contributions and suggestions from various people who mounted this stage to embed it into the blueprint of the vision we have for GACOPA. And he's going to present that. So I want everyone to be attentive. That's why we spelled GACOPA with our waist. Everyone should be attentive. This is a very important part of this conference. So with a resounding round of applause, let's invite onto the stage the Vice President of the Global Association of Clinical Officers and Physician Associates, Dr. Antonia Asare-Akon. Please, let's give it up for him. We almost look like twins this morning, you know.
Thank you, SG. Thank you, everyone. When I say GACOPA, you say a global synergizer. GACOPA. GACOPA. Thank you very much. This presentation is sanctioned by the International Executive Council of GACOPA, and also it's our, the presentation is actually summarized. I will talk more, and then it's our eyes and brain. That's why we are here. We held the first meeting in Ghana, 2019, and subsequently in Rwanda, 2020, went to Malaysia, and we are here. Next year, we will be outside Africa, and I'm not mentioning it, and it's going to be such a great time for us. Okay. So I am speaking on global strategic impact, what GACOPA envisions, or the vision of GACOPA, what we have summarized. Okay. Okay. I'm not here to talk about myself. So I also double as the president for the West African Association of Physician Associates, is the West African chapter of GACOPA. We've been doing a lot. In fact, most of the things that the East African chapter is doing, we have also gone through ECOWAS and the West African Health Organization to harmonize. I'm told the process can take about 8 years to do it. Recently, I was in Burkina Faso with the Secretary General to see the Director General of the West African Health Organization in order to harmonize our practice. All right, so this is what we want to do. This is our whole vision. The whole vision is to universalize our practice, the universalization of our practice, for which our distinguished guests, our professors, and our distinguished keynote speakers have already presented on it. And then the process to go about it, we have taken a lot of learning and presentations from this. It's become very necessary because before we formed GACOPA, earlier on, somewhere around 2015, 2014, we had a lot of discussions that were ongoing. Dr. Manasseh Bocha has said it, how there was an existing African network of clinical practitioners and the West wasn't involved. We also had the International PA Organization, Physician Assistant Organization, made up of the West only, and other parts of the country, of the world were not involved. In fact, when we met in Rwanda, all the world, they were there, Australia, Ireland, we had Canada, we had everybody coming through. They all came. You would have seen a lot of, colored faces there. And they were actually shocked to learn that there were even people called clinical officers. So the likes of Mary McKay, Mary Shostak, Lindsay Milcarrick, and all came in, Professor Lisa, they all came through, and such an outstanding work by the president to also spearhead and lead, bringing all these people together. So GACOPA became the platform, the body that actually brought all these factions together, from the network of clinical practitioners in Africa, those from the West International PA Organization, those in all parts of Africa, came together to form GACOPA. And all the associations that have been produced yesterday, you saw the projections, have been the work of GACOPA. Can we clap for that? Okay. So, in order to universalize, the first thing we have to do, or we have spoken about or thought about, is the GACOPA governance structure, which we have discussed. And as we meet to have the Conference of Presidents meeting, some of these things will be discussed too. So GACOPA, we are actually working on our internal government structure. We have representations in all continents, where we call them directors at large: Africa, Latin America, Asia, Mediterranean, Europe. We have all representations. But as we were moving on, a lot of, apathy has set in, and we also decided to change our governance structure to reflect what is done in the world. So currently, or as we go on, you get to know that the GACOPA International Executive Council will have some positions like, various vice president that will be elected from each region. So Africa will have a vice president nominated or elected by national associations in Africa. All national associations or president of national associations will come together and elect one person to represent Africa. At the time we were forming, we had director at large by appointment, but this time we are going by election. We go to Europe and do the same. America too, we had a representative there for the Americas, and we will also elect for all the continent, and all these ones will occupy like, a vice president position with various, what do we call it, requests or various duties. Then we have what we call the COPs, the Conference of Presidents. The national president who are electing these ones are to be fully integrated into GACOPA, so that decisions taken at GACOPA conferences will be easily disseminated and carried by the national leaders to their members. So we are going to involve them in decision-making, policy-making, and everything we are going to. In fact, WHO, World Health Organization, is going to a perpetual partner. You cannot be a health organization of this level where you don't have this strong bond with WHO, which is also with the UN. And so we are entrenching and strengthening our association with the World Health Organization. IAPAE is our strategic partner in education when it comes to everything in relation. If you want to talk about practice, you should be talking about education, curriculum development, harmonizing it. And it is the International Academy of PA Educators who are responsible for it. And we have President Scott here. So IAPAE is our main, what do we call it, strategic partner in education. And of course, you cannot do anything without politics. We have to ensure all realms and at all levels of engagement. We saw politicians. You can take all decisions. Employment, policies, if conditions of service, is politics. And we need we need clinical officers to go into parliament. We need clinical officers. In fact, recently, the president of the American Academy of PAs wrote a letter to the president of the American Medical Association, in fact, accusing him, of course, and confronting him of blocking about 100 bills in parliament in the United States that could improve the lives of physician associates. And the letter, I wouldn't be able to project it. And these are some of the things. How was the leader, the president of the American Medical Association, able to block bills in parliament? And so if we ignore the political part of our organization, then we are doomed forever. And most of the things we are suffering, or undergoing or going through in our countries is because we have less political will and involvement. And so this is our strategic partnership with other subdivisions. All right. So we talk of standardizing training and certification of the IAPA, for which IAPA is doing. They are bringing all curriculums worldwide into one, harmonizing it into just a single one, just one, so that like our professor, doctor, was here, the chairman of the council, spoke about it, so that we can have a united curriculum. You go everywhere, MBBS is MBBS, MBCHB is MBCHB. They have a good foundation. They have similar courses that runs through, credit hour courses that runs through, but all of us, some are certificate, diploma, and other things. We want to abolish it completely. We want to abolish it. So clap for AIPAE president here for the work he's doing. We are requesting that the IAPAE has an authority to make sure or institute the National Academy of PA Educators. Not every country, Ghana doesn't have it. There are PAs who are teaching, we have clinical officers, educators, but they have not come together as an academy or an association or organization. So we want you to write to all the countries in the world Tell them that this is the body that is the nationally or internationally recognized body, and we want to establish. So we pull all the professors together, and then all the things that we are talking about can be implemented easily. So there are in America, I know they have National Academy, and maybe South Africa, you established it, but I don't know about Kenya. There are lecturers in different, but have they come together as a collective group where you can say that, okay, you can pass down this policy to them? Ghana doesn't have, Liberia doesn't have, we don't have it in Cameroon and others. And I think that training has also reached level. It's easy to move from diploma, bachelors outside the country, US, Canada, and all. They are doing masters. That is the entry to practice now. Do we have to come back to bachelors? All depends on you, IAPAE. If you can establish that, okay, because Professor Mary McHale was at our last conference sometime, and she told us that they abolished the degree about in 2000 or 1990s or so in America or so. And so wherever you have to meet. Now, we also request that you communicate this decision, IAPA, communicate this decision to the ministries of health, that this is the curriculum. We want you to engage. If you have to travel to all 84 countries, do it. Subject to funding. Ministries of education. So there are regulatory bodies that are in charge of, institutional accreditation nationally. The institution in the country must be recognized by these bodies, regulatory bodies, and then GACOPA and other regional professional bodies like the network of European PAs, IPAO, and or PAGH, all those advocates. Write to them that it's a decision. I want IAPA to move from an academy or an association into an authority body, so that as long as we are taking, I'm saying this because you talk of the World Medical Association is an authority body. It's big. The International Council of Nurses is an authority body. They decide, and as long as there's a consensus, they pass it down. And of course, most of the things going on are carried from there. The International Federation of Pharmacists is an authority body. They decide on international policies and then legislations and discussions and resolutions that is passed down automatically because there is national representation. We are also looking at this, that our skills have been called into questioning. Our training has been called into questioning. And most of the time, if you look at the things that we suffer in most of our countries, they have subjected, let me say this. There was a situation in a surgical department where a circulatory nurse with a very low, degree qualification, who has been working with a surgeon for 10 years, was actually in another facility. And then there was a doctor who was operating, performing appendectomy. Took so long. So they went to call this woman. She came in, dipped her hand in, and brought it and said, "Are you looking for this appendix?" And then the surgery continued. I'm trying to say that this is what they are trying to say. Let us think for the doctors. Let us think for those coming to receive medical care. They think we are partially trained because our curriculum is inadequate. This is what they think. And is it true as well? I am a representative. I have partnership with Ukraine. And I think some few people know this. We have brought a program called Master of Medicine. And of course, we have studied the two curriculum. We studied all the curriculum in West Africa. And whilst PAs were entering into the Master of Medicine program, we did what we call reworks. They compare curriculum, credit hours, and there was a vast difference. In fact, about a whole year. Let us not pretend that the curriculum is the same. I've seen the MBBS, I've seen the MBCHB. It is not the same. Now, this is what we are trying to advocate. You are going to share, we are sharing the consulting room with a medical doctor, a dentist, we are sharing or taking the glory, the recognition of a medical doctor and dentist. And the patient that sometimes we see, some of them will never see a medical officer in their lives. Has become the cornerstone of universal health coverage. So primary health care is to make it accessible, financially affordable for people. I cannot walk well, and I have to see Scott, so I have to come all this way, right? And by the time I get here, I'm tired. And I have to wait for the train or the roads, and the road is bad. But if I had this problem, and there's a professor, a surgeon here, I just come and then see him. So in primary healthcare, it reduces the cost of transportation, the stress in transportation, and makes you accessible. And it is the culture of training, not the content of training. Okay? Let us make the content better, and MBCHB-like, have enough knowledge to take care of patients. That is the problem with doctors. You want to take care of a patient with diabetes, have the requisite knowledge. Look, Ukraine, when we were doing the differences, I saw that our curriculum, even in clinical anatomy, we had about 10 credit hours. 10 credit hours difference. Pathophysiology and physiology, about 9 or so credit hours difference from all countries. And so they said the medical student does more than the CO student. But you are seeing a patient to treat hypertension. Why can't we put it in the curriculum? Now medicine is even 4 years, and we also train for 4 years. So is it not the credit hours? Can't it be improved? If it is cost, then add up. And then we focus on that. So this is the focus on, there's a focus on financial risk protection. Let us improve our curriculum. Okay. Now, in standardizing our practice and what is happening around the world, GACOPA has a vision. We want to establish the GACOPA Specialist College. Can we clap for that? So those investors, connected businessmen amongst us, we want to have a division of the college, like, the surgical division for membership training. Nurses train and become specialists. They do residency. This is my problem. In America, I was asking Professor Merkel, maybe Scott is here. I asked. They call them dermatology physician assistant, physician assistant cardiology. So I asked them, are they specialists in the field? These are not specialists compared to doctors. I'm saying the focus should be on primary health care. So if you are trained as a pediatric specialist clinical officer, the focus is that cases that should not travel that long and far, you take care of. And then regional hospitals, let us accept that our culture of training is for the rural areas and the underserved communities. And you are trained to go there. Can't we also have a college like this and train for membership, train in fellowship, and then continue? So this is our vision, and we will achieve it. In fact, in West Africa, we have the West African, we have initiated it. You submitted a proposal to WAHO. We went to ECOWAS. We submitted a proposal to WAHO, the West African Postgraduate College. We have instituted the constitution. We submitted copies and what do we call it, prototypes of syllabus to them, curriculum to them. And it's been worked on and looked at. Okay. Then, part of our universalization of practice. Now we are done with training. Scott is going to handle it for us. And we've also told you that we want to also help partner and build a college, a specialist college. In fact, this thing, the country that will be ready to help us build this college, in fact, will bring a lot of resources. I know many countries, their regulatory council, professional bodies might resist. If Kenya will come in, we will mobilize the whole world and lecturers to come in, and it will be a historic establishment. And we can start training. So you can look at it, and then we can discuss it. Now we have the IAPA classification of the global term, registered clinical practitioners. And this is distinguished from registered medical practitioners. This is one of our major problems. In fact, in UK, the physician community have risen against the General Medical Council that associate medical professions or PAs are not medical practitioners. And then the General Medical Council have used the term medical professionals. The physicians are saying it conflicts. In Ghana, one registrar of our council stood somewhere and said, we are not medical practitioners. In fact, there was a case in court, and I had to petition the Attorney General because one of our persons became witness in a sexual abuse case, a rape case. And he was the first point of contact at the time. when he signed it to court, the registrar, the person defending the accused, was actually of high rank and the Ghana Health Service attorney. So he wrote to our council that can PAs endorse medical legal issues, and the registrar wrote back to the court that PAs are not medical practitioners. They cannot endorse. And so they contacted us, and the guy called me, and I petitioned the Attorney General because the case was the Republic against the accused and enumerated. At the end, the Attorney General ruled in our favor, and it has become a precedence for us. And now PAs can sign medical legal issues because of that. So we want a name that will distinguish us from, because the registered medical practitioners, I am told, and we have seen and known that it is a legally protected name for doctors. And so the International Labour Organization has actually gazetted it as a legally protected name. You are a medical practitioner because you practice medicine. But they have gone first and says that this is our name. And so you cannot take it. And that is why it has become very necessary for us to adopt this. Now, IAPA is the educational, internationally recognized representative for educators. And that is what they are bringing. And if they bring this thing and institute it through the schools, it will resonate. Because sometimes you train and on your certificate, it's something else. Somebody is called nurse anesthetist. Goes to the council and say, register me as a certified registered anesthetist. Or a doctor assistant who goes to the regulatory body and says, register me as clinical officer. So we want that to be resolved for us. And we are here today to declare, adopt, and enforce that clinical practitioners has been accepted by GACOPA. Can we clap for that? We also thought that doctors, or we have been discussing that doctors have, even though they are called registered medical practitioners, they are called medical officers. They are called medical doctors as well. Except you take nurses and nursing profession, they have all the different types and still nurses. And pharmacists remain as that. So clinical practitioners is the classification for International Labour Organization. And we are adopting it. And we have come to say that in addition to clinical practitioners, these are the two names that has been resounding. As for the assistant, Ghana voted against it. In fact, the whole of West Africa have voted against assistant. So we recently changed the WAPA, West Africa Association of Physician Assistant, to associate. And I know that we need to adopt this in order to enforce it at the national level, because names are produced by law and through parliament. So when we take the decision and accept, we will communicate it through all national associations and then ensure that it is done. So this is what we are going to declare at the closing ceremony. These are the two names that we have come out with: clinical officers, physician associates. And to resolve all the discrepancies, community health officers, doctor's assistant, physician assistant, clinical associate, health licentiate, and all is done. We don't need it anymore. We have clinical officers, physician associates. Classifications still remain as clinical practitioners. Clinical practitioners. And I'm told that the Scott is going to actually, they are going to amend the clinical, or adapt the clinical practitioners with physician associate. In fact, even in Ghana or West Africa, the associate physicians, we were not going for it. I have to tell you, but there are places like America, let me stand here and tell you, America won't change it. Because some of them told us that when you use officer, it refers to either the military or something like that. So we will keep these two names for now. Hopefully, we'll be able to arrive at a singular name. So like somebody is called medical officer and medical doctor. We also have, and they are also called registered medical practitioners. We are called registered clinical practitioners, physician associate, and clinical officers. Thank you. Even in Ghana too, let me refer, the ranking, they rank it as medical officers and they don't rank it as medical doctors. So we can even still stick to the physician associate and rank it as clinical officers. However, but these are the names and we are done. Are we okay? Okay. Now, the next GACOPA project we are going to do or have is the Global Prescribers Formulary and Guidelines on Rational Prescription. A lot of our people, even in South Africa, they need a supervision, a co-signer. There are many places in UK, they can't prescribe medications. So we have a 5-year strategic plan to set high-learned committee members so that we will come out with our own prescribers formulary. We are focusing on research scientists, academia, pharmacists, biochemists, IAPAE. You are always there because you are developing the curriculum. You know what you are teaching in pharmacology, what can be done, what we can do, clinical officers, relevant policy makers. So we are going to bring our own prescription manual, right? Our own prescription manual, like the British National Formulary that is being used, the nurse prescribers formulary, the dental prescribers formulary, all those things we are going to bring and we are going to globalize it so that as long as we are universalizing practice, then every part of our practice should be universalized. Can you clap for that? So this is work. Those learned colleagues amongst you, we are going to work together, and these ones are going to be produced. I don't know whether it's going to be after we are done with the work annually or quarterly or semi-annually. We will do that. So all of us are going to be really, really busy. Really, really busy as we have this vision. In fact, this is for the whole of GACOPA. So in case they open a forum for questioning, the president is there too. Okay. Yes, professor said it. And this has been prepared in advance. And you can see the coincidence. The GACOPA Journal of Medicine, and it should be research rather, and surgery. So this is our journal that GACOPA is going to launch. And so when professor was speaking, I said, professor is a professor. So to advancement of research, publications, and dissemination, and we need to do it. We need to do it so that at every policy sitting, we can pull it out and bring it out. And we have the learned people here. So GACOPA is going to have our own journal, and we are going to publish it every quarterly. And some of you are going to be on the editorial board. You are going to have a lot of work to do, and let us plan with a lot of funding. Now, this is also a project for us. And this project is also to partner the specialist college. We want to build a medical center of excellence. A medical center of excellence. The GACOPA Medical Center of Excellence, where we have a big facility to partner the college so that people can train there. We want to also disseminate these centers maybe to region, maybe Africa, Eastern Europe. You go to everywhere, we get partners, and then we are able to, then we can bring it to maybe national level and even create network of practice like the Doctors Beyond Borders you have seen. In fact, working with, and then we have partnership with the Conference of Presidents, that is national president, to ensure that these things are done and we are going to achieve it. Can you clap for that? Some of you, of course, you'll be the ones to also work. It's going to provide some form of employment for you administratively and clinically. And this is the vision of GACOPA. Are you here? Okay. So you have to sign up. Oh, sign up. If you are not a member, then we have the National Employment Advocacy. It's becoming a lot. It's like you train and they don't need you. You are not like critically needed. And this is what I'm saying. If we are able to define that we are primary healthcare practitioners, we are coming in, government, you won't spend this amount of money. We will help you with financial risk protection. We will help reduce, the propensity for poverty because of out-of-pocket expenses. We will be considered. That should be the argument when we go to government. So in partnership with the Conference of National Presidents, the International Health, and then other international health employment bodies, WHO, public health and private international agencies. There are some who come and they need healthcare workers and they are going for it. The nurses and doctors and PAs are not there. We want to explore. We want to go out and do it. National employment agencies as well here. We will write to them. There's a cadre here and they are unemployed. This is what they do. The port, there are companies, they need clinics inside their companies. Some of them need consultants, you understand, healthcare, bankers, and all these places. Let's go to them, then private. Then bilateral and multilateral agreement, very, 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 very important. With countries. Let us have agreement with countries. Let's go through the ministry and then have agreement with country. And this is what we are going to do. So we go to a country, we look at their health force, their problems. Nigeria has a lot. We say we are registered by this, we are recognized by this body, and so our people have not been employed. Doctor assistant, they are here. Let us institute that. In fact, when we started this bilateral agreement, we are doing it in education. So we have partnership with Germany. We are doing one. We've been exploring how to get to United States, and it's a bit difficult one. So what we did was that we partnered, this is WAPA project. We partnered, and WAPA is GACOPA, the Northeastern University, Boston, on their Doctor of Medical Science degree. In fact, it was very difficult because you have to have a Master of PA in order to do that program in the United States. So this was the only university that actually permitted this, and we have partnership with them. We have partnership with Ukraine. Ukraine, they told us that they wanted to start something like, the partnership is with VN Karazin Medical University, and then also Ternopil University. We also have partnership. What they wanted to do was that they said they wanted to train something like military medicine. The war has actually impacted their life, especially the Eastern is still ongoing. And there are a lot of people are going there, and they are paid huge. And we can explore all these avenues, and GACOPA must lead us into this international or bilateral and multilateral agreement. So in conclusion, we are looking at our journal, we are looking at our medical center, the GACOPA Medical Center. We are looking at creating jobs, both in our offices, establishment, and also having bilateral agreement, multilateral agreement with companies, WHO. People can work there. The health, WAHO, West African Health Organization, East African Health Organization, I don't know what it is called, European health forums. Let us explore. This is what we are going to do, and then we can go ahead and also have the Conference of Presidents as well. So we want to have this, and this is GACOPA Strategic Impact. Thank you very much.
Thank you very much, Dr. Antoniakon, for that comprehensive vision that GACOPA wants to outline. And ladies and gentlemen, you agree? Yes, there's a question there. I'll go for it. Ladies and gentlemen, you agree with me that this vision is a very comprehensive one, and when it follows through, when it is able to materialize, the stories of clinical officers and physician associates around the world will change. And it will change for the best. So it takes your effort, it takes my effort, it takes our collective effort to make this thing a success. So please, in your area of expertise, if you are called upon to come and offer some help, to come and offer some assistance to this vision, please do it with all your might. Because you are doing it for yourself, you are doing it for us, you are doing it for posterity. Your name will forever be remembered. Thank you. Mr. Washira.
Yeah, thank you. Let me say that I'm very happy today, and that was a very good presentation. In fact, is what I've been waiting for. I have really been concerned. I'm sure I've shared my concerns with you. Mine are, I think, contributions. Number one, when it comes to the nomenclature, I think it is best suited, as much as one of the pillars, which is IAPI, is doing it. I think the presentation to the ILO is better done by GACOPA itself. Because out there, you know, when it comes to IAPI, it is seen as a strata of clinical officers and physician associates being the educators. So it is not seen to be comprehensive in terms of representation of all of us. But now in GACOPA, actually IAPI is seen as part of GACOPA, as the educators of ourselves, but then we have the regulatory bodies, the associations, and the unions. And so, in my opinion, when it comes now to the presentation of the title to the ILO, it is better presented by GACOPA, and my suggestion is that if we can also have some letters of endorsement from the national associations from all the countries supporting, probably that would better help in doing that. The second thing is that the vision is comprehensive and very ambitious. And it will be intensive in terms of the funding. But then I know that we are going to have that opportunity to be able to discuss that. But then we must be able then to have a strategic plan that is going to detail so that we know exactly when to do what and how much we will need for that, so that then we can be able to approximate the cost and see how we'll be able to raise it. Thank you.
Just a question.
Thank you. Thank you, Ako, for that good presentation. Indeed, you have summarized the sentiments of this conference. I just wanted to top up his answer that we really want GACOPA to be the UN of the clinical practitioners. It is the United Nations of clinical officers. All the other bodies will be under GACOPA. Therefore, there was that diagram which you presented in slide 1, where we have the Conference of Presidents, then we have WHO, then we have the political wing, and we have IAPE. So amend that one and include regulators, include unions, and include trainers, students association, and researchers, because we have presidents of students associations, so that we move together as one entity. Then we are good to go. Then you had earlier said that the next conference for GACOPA will be outside Africa. And that one is by design, not by default. So that when we go to the outside Africa, we are going to make sure that the membership of the presidents or the leadership of GACOPA encompasses all continents. They should take leadership so that it is really seen to be international. Thank you.
Thank you very much, Dr. Manasseh Bocha. Scott.
Great. Thank you, colleagues. Thank you, Vice President, for your wonderfully passionate delivery and speech. I heard 6 months in preparation. And I can see the truth in that. Really impressed with this vision. I wrote six action items you guys had, 6 vision items that you had, which is really impressive. And IEPA was part of a lot of that. And I'm honored to be here representing IEPA as the current president. Our president should rotate each year. Our next president is Lambani Sosetsi. She will come in as president at our next conference. And then following that, our president-elect will be Dr. Joseph Choge from Kenya. And Dr. Choge will become the president of IEPAE in 2025, the 16th annual conference in Nairobi. And we're partnering with the Kenya Clinical Officers Association, and we're really going to be very proud of that. So I can carry this back to IEPAE, and I know that our presidents in line will also be following it. You know, for a long time, IEPAE has been wanting to represent globally and always include, and we have 5 regional directors that are filled to work at that. And we've done a really good job since 2007 to be globally represented. And I know GACOPA is working on that and moving on that. And you started here in Africa, but you're growing outward. And I'm really pleased about that. I'm glad that I'm here helping to represent that. IEPA would be wanting to partnership with GACOPA and continue. We do have to recognize we are separate associations, and that is important. And that IEPA is not under GACOPA, but IEPA is standing with GACOPA. And I think that's important. And we want to be there. And we are the educators of the PA clinical officers around the globe. And you are the professional association of the PAs and COs around the world. And I actually like that role of the UN, and I think GACOPA can lead that role. And we are here just as much as the unions also are separate and stand strong. And just as much as the country associations are with you and stand strong. Because each of us have our unique role that we can bring. Just like the discussions of our task sharing amongst our healthcare teams. And we have our roles to play. So I do want to acknowledge that. And IEPA will definitely stand strong. Definitely stand strong in that. And I'm really pleased that IEPA has been growing in the last several years. We have many representatives from Kenya within our organization. I do want to acknowledge that Margaret Maina is here. Margaret, stand up for a moment. Margaret Maina is our secretary of IEPA on the board. And really pleased about that. And we also have with us our chair of Innovations Committee, Xavier, already standing. Very happy about that. And we had many representatives here in the room who came to our last conference in India. I'm so pleased with that collaboration. We have our elections coming up at our IEPA conference in Lynchburg. It's an online election. You don't have to be present. But if you are interested in joining our organization, we open that up for elections stating. I wanted to make a comment. You had said that the accreditation standards should be done, and that's what we're working on with our LOOP project. You know, the LOOP is the curriculum mapping. And we have 46 educators around the world. Many of them are here, many countries represented. We want to grow to the 80 countries, and we will together map the curriculums. We will present accreditation standards. What is a standard? Minimum bachelor's degree with entry requirements. Minimum standard for master's with entry requirements. PhD, and we recommend that globally. I think at now, the minimum standard probably is a bachelor's degree. And I think it's something that we work towards a master's. But we don't want to exclude other countries right now that are at diplomas and support them to move to a bachelor's. And that bachelor's could be our minimum standard, and maybe 3 years from now, that's where we should be. And and of course, I really appreciate this global term, and I'm so pleased that we are coming to unification of clinical practice, and that we are all clinical practitioners. But within our own country, we may have our term clinical officer, physician, associate, other terms that we have. Like a doctor says, I'm a doctor, but actually I'm an anesthesiologist. Or I'm a doctor, but I'm a cardiologist. Or I say I'm a nurse, but I'm an ICU nurse. Or I say I'm a nurse, but I'm a mental health nurse. So we are clinical practitioners, and I'm a clinical associate in South Africa. In that way, I like that. And so there is a PA-CO working group for ILO, International Labor Organization. And this started conversations with many of the Kenyans in the room and with some of the American PAs. Jennifer Ames, who is a representative of AAPA, sent a motion to the House of Delegates that said we should direct our attention to ILO and request a name change. And that started the motion. And so people have come in and out of this ILO PA-CO working group. And over the years, we've drafted several recommendations to present to them. And just recently, a month ago, we presented to ILO the clinical practitioner term. And we presented an expanded definition of what we do, which included for the first time being specialists in areas. That was presented, and that was reviewed by ILO working group. They came back with a response 2 days ago. And 2 days ago, the response was that they appreciated the expanded definition. However, they would consider the term physician associate, as that term is currently being used in many standard occupation classifications, such as the United States, in Canada, in Australia, in New Zealand, in the UK, and that the clinical practitioner is currently used in one country, being Kenya. Kenya led the way with adjusting their standard classification occupations. I think though, as a working group, we don't want to be choosing just one particular name. We want to have a global unifying term. So in discussions, and I want to hear from you, either now or see me, is that we're going to go back and propose clinical practitioner and physician associates. Even right now, the presentation, though, makes me think we should present clinical practitioners as clinical officers and physician associates. And perhaps we can get all three of those.
Yes.
Clinical practitioner is our global term with clinical officers and physician associates. Those are the two most common terms. 10 countries clinical officer, 23 countries with physician assistant or associate, PAs. You know, that seems to resonate, but feedback. And so I'm going to collect your comments and help facilitate the PACO working group to continue to discuss with the ILL working group so that we are together. And our 5 regions will be represented also, not just here today, but we'll get feedback from others so they come into that, because it's a collective for us to present to ILO. Okay, thank you so much on this.
Yes, thank you very much, Scott. Any other question? Vivian had a question.
We have the lady here.
Thank you so much. I have like 2 comments I will need to comment. Number 1, we have enlisted things that we want to do as GACOPA, but I feel there are strongholds, and if we can be able to work with a few of them, things that are achievable, things that we can be able to do as we leave this place. One of the things that I'm feeling we can be able to start is having the GACOPA Journal of Medicine and Surgery. This is something that we can contribute as editorial boards. We can even sacrifice our time and volunteer to make it a reality, and it's something that is achievable. So for us to be able to have this GACOPA journal, it's something that if we put all our minds together, we can start even as we leave this place. So that is something that is right here in our hands. And I think as GACOPA team and the leaders, this is something you should run for. The second thing, I was looking at the programs that we were thinking of starting. We have a very clear and distinct institute in Tanzania which offers dermatology, and we have almost all African countries coming to that institute to train for dermatology. So if we can have just one specific course, for instance, we had talked of military medicine. It is very unique. The others have not even thought of it. If we can pick it and say maybe we need to have just one common college training clinical officers in military medicine, it will give us a high notch and we'll be able to move as we continue. I'll also want to bring to our attention about the COSESCA program that is going on in Kenya, where the medical doctors from East Africa and Southern Africa have come together and they train the doctors in different institutions as a program, not as a college. They do different programs in medicine, different programs in surgery, and they train at a lower cost compared to the universities that are around. So if we can pick the military medicine, maybe there's something that we can venture into, and it will be very distinct for clinical officers. Then the other area that we can be able to go for is anesthesia. Most of the countries that are offering anesthesia is being offered by the clinical officers or the PAs. So we can run with anesthesia and make it like our own. So maybe with these 2 programs, we can give it a high five and run with it. Then the other that I want to talk about is the strategic plan that we need to have as GACOPA. For me, I feel us having an annual event for GACOPA, it might give us a bulk of ideas that we might not be able to achieve. So if we can have it maybe after every 2 or 3 years or 4 years, just like the way we have World Cup, it will give our countries more time to work on issues. And when we meet at GACOPA, we can be able to try and analyze if there's been research that has been done, it's research that has been proven, it has been tested and proven to be right. So we'll have a very bigger platform and people will plan for it better and we'll be able to have different arrays of ideologies. So my submission is if we can be able to maybe the GACOPA conference, maybe not annually, but we give maybe after every 2 years or after every 3 years, to give us time and even to give the team that is on the the team that is governing us as GACOPA more time to at least do the work that they're supposed to do. You can imagine every year you move as GACOPA and you have a country like Botswana that needs to strategize, you have another country like Ethiopia that needs to strategize. So if we can come together and say, let us have maybe after every 3 years or 4 years, let's have a bigger GACOPA conference that will bring better changes as we want. Thank you.
Thank you.
Thank you, Mr. Vice President of GACOPA, for your rather hope-filled presentation. Listening to you, I can tell you that a lot of clinical officers and all over the world will be filled with so much hope. Yes, we've been having these discussions for a very long time, but then now we are seeing some visions of a great progress and improvement in our profession. I have 2 questions. The first is, what is the roadmap to getting these goals and visions of getting GACOPA College realized? You have shown us the vision, but I don't think there was a clearly spelled roadmap to getting these things, realized. Are we going to wait 50 more years? All right. Then the second one is, in the interim, do we have a plan on career advancement for members, even if it's outside of their countries? How does one access information on such programs? Because for some countries, we are limited in our practice. And in other countries, they have been supported by their governments and councils to advance in their careers. Listening to my brother from Sierra Leone, you could see that clinical officers in Sierra Leone are doing surgeries. In Ghana, it's not allowed. It's not allowed. So you are in a very remote part of Ghana, and then people are dying out of, ailments that could have been addressed by PAs, and they could have cut down a lot of costs getting medical attention. Is this information accessible on the GACOPA website? Is it possible that we could put these on the GACOPA website so that members from other countries can access them, and then if it is possible to go and pursue them outside of their jurisdictions, I think that will help. Thank you so much.
Thank you very much, Mr.
Thank you so much. Before you respond, thank you for the questions. I only have 2 concerns, kindly, if you allow. The first one is that during the presentations, quite a number of presenters, what I've been hearing, and it will need some further discussion to clear out the level of operation for clinical officers or physician associates. When we talk about primary health care, what do we really mean? Do we mean rural health, or what do we mean? Because most of the speakers, they are inclining clinical officers' practice to rural areas. We need to have a clear definition on what we mean by primary health care for clinical officers. The second one, I don't know if it will be answered right now, but from the presentation, thank you, it was so elaborative and very nice. But the question is that there is a level you said it should be standardized, a recommendation on standardization of the levels of practice for clinical officers and physician associates at the master's level. What I want to echo is that
Clinical officers in Africa, most of us, we are starting at diploma levels. We have then the degree levels, then the master's levels. I think, and I remember very well last year when we were in India, during the IAPAE conference, we talked about the levels of training and how clinical officers are trained in different countries. We found out that actually in Kenya, the Kenyan curriculum actually, by the time one is finishing a diploma, that is almost a degree level or towards masters. Because 3.5 years doing a diploma basic, then 1 year mandatory internship, that makes 4.5 years. Then 3 years in practice, that makes it almost 5 years. Then before you go to do a higher diploma. So actually by talking about standardization level, we should find out on how to talk about it. We need to have a discussion. It should not just be deliberated, but we need to have a discussion at what level. And basically I recommend at least a basic degree. Otherwise, I submit. Thank you so much.
Thank you very much. I think, okay.
Okay. All right, thank you, Brother. Even though you spoke last, I'll address yours quickly. I think when I was speaking, we all understood what primary health care is. It's reaching to underserved communities. So there are even urban areas, okay, in urban cities, which have even growing communities that do not have access to healthcare. And what we have to do to make ourselves, making healthcare accessible. That is what we have to present to government and policymakers. So there are places that, and we have a culture of training. We should get it. If you want to be a primary healthcare practitioner or be involved in primary healthcare, we are talking about universal health coverage. We should be ready to go where others won't go. And it should be part of our training. And I'm saying that, or we are saying that, this does not mean that you have to downgrade the curriculum, because lives in the rural areas are not lesser than lives in the urban areas. We practice in the city, we live in the cities, we have professors and ministers in the cities, their mothers are in the villages, they are in underserved communities, in remote areas. Their lives are not lesser than those in the area. So if you are training somebody in, what do we call it, in the urban area, is trained with superior knowledge of medicine to attend to somebody with equal lives, okay? Equal lives or have right to live, and then they send another person to see the mother or the cousin in underserved communities and say this one is not trained to this level. And this is what I'm trying to say, that basically what we can improve, it should be the culture of training. And as much as we might even make it faster training or quick training, I have even seen just 1 or 2 universities somewhere in Europe or somewhere where they wanted to even make medicine 3 years. But you look at the content, and I have studied it. There's nothing like wanting to regularize what is not there. Diploma is diploma. If the content fit a degree, give it a degree. You can't say I'm a diploma and at the level of a degree. We don't do that. You can't say I'm a degree holder and my level is a master's. You cannot rationalize. You have a lot to explain. So if it qualifies as a degree, submit it and then file it as a degree program. If it is a diploma, when we do this, because let's know this, our origin, where we came from, Ghana, we started as a certificate. It was on ad hoc basis in 1923. They were called dressers. We need people to assist the surgeons and to do these things. And then somewhere in other countries, started as certificate. And they saw that, okay, you have become important. And we improved and improved, and we have improved. But we've gotten to a point where medicine has become so complicated and complex. You understand? So this is all we are saying. It's in the hands of the IAPA. It's complex that when COVID came, we saw what happened. So let us regularize it. The last one has to do with our, my other, then you come in, the PH, our meeting, annual meeting. In fact, there is no thing, any other day we speak. And the leaders, we speak. We communicate with each other. In West Africa, in Eastern Africa, they are always, and they are leaders of national unions and associations. So problems that are enrolling or on rolling basis are discussed. And most of these global associations, it's worth that you meet to discuss what you have done the previous year. There are some strategies or roadmap that will take 5 years. Some will take 10 years. Some might take long time. But there is need for you to come, be abreast. Because every day there are problems that happens in each other country so that we can meet. I will give to the secretary to answer.
Okay, thank you very much. I think I'll answer Gordon's question, even though he's not there. Yes, so he was asking for the roadmap for, yes. So there is a comprehensive document for that is going to be launched. You understand? Yes. We outdoored this one so that we can all be abreast with the vision that is going up. There's going to be a comprehensive document that will be launched. And before that one is launched, all the national presidents will be consulted. We are going to have a consultative symposium to develop that document. You understand? We are not just going to sit in a room somewhere and do this because we are leaders of GACOPA. No, it has to be inclusive. Inclusivity is a harbinger to success. So if we include everyone else, that is when we are going to see real success when we start. So there's a roadmap that we are going to follow. And they asked, would the information be available on the website? Of course, it's going to be available on the website. I think those are all the questions that came in. Yes. All right. So at this point, we will move on. Far behind time, you see we've launched ECT. That means there's going to be a lot of big talks going on here. Yes. So the next session is the symposium of the Global Synergy Symposium. And this one involved the Conference of Presidents that we've been talking about, Conference of Presidents. Who are they? We are going to see them here. And this session will be moderated by the one and only Peterson Washira. He's the chairman for the Kenyan Union of Clinical Officers. And the panelists are going to be, okay, the president is going to outdoor the panelists.
So as Peterson Washira gets to his feet, this was a decision that we made that we really wanted the decision makers, the presidents, the chair of societies, associations, unions, so that we can come together and discuss how GACOPA, we can really move GACOPA forward. And it's here that we are also going to discuss about the planned leadership. We'll be having leadership sessions and forums or symposiums, and also how we can really have a GACOPA that is financially stable. So as I invite these key people, I just want to tell you that there are people who will be joining us virtually, and we are sorry that the president of the India Association of PAs was to give a keynote address just immediately before this session. But because of time, she will give a recorded keynote address, but she's joining us virtually. So early this year, on the 15th day of May, that was Wednesday, the Kenya Union of Clinical Officers began more than it's now a record, 100 days nationwide strike. And it is at this point that GACOPA rallied members, lead association, union, and society institution heads to join, and they gave a press statement on the 15th day of May. It was done in Nairobi, in solidarity with the Kenya Union of Clinical Officers nationwide strike. So the people who are present at that time, I'll just mention their names, and then from there is when now I'll invite the who are also association presidents. They are also representing the president. Some of them did not make it but sent people. So at that point, the people who were in solidarity were Alhaji Mustafa Majid, the president of the Malaysian Association of Medical Assistants, MAMA, that was in Putrajaya, Malaysia. We know Alhaji Mustafa Majid. is the one who hosted us during our last conference in Putrajaya, Malaysia. And I know a quarter of the people here attended that conference. It was really nice. It was done nicely. Then we also have Maluo Maguru, is the president of the Health Extension Officers Association of PNG. PNG is Papua New Guinea. So Maluo Maguru. We have Peter Andungu Ayamba, who is the president of the Ghana Physician Assistant Association. Solomon David Chomba, president of the Physician Assistant Union of Malawi. He's also a GACOPA executive. Neba Jones, president of the Clinical Officers Association of Zambia. Bob Estimate Katumwa, president of the Clinical Officers Association of Zimbabwe. Data Rama Abikari, president of the Nepal Health Assistants Association. We have Uyapo Maweni, who was the president of the Botswana Clinical Officers Union. Scott Smalley, president of the International Academy of Physician Associates Educators. Innocent Wilson Somboi, president of the Tanzania Association of Clinical Officers and Clinical Assistants. In Tanzania, they train even at certificate level. We have Shivakumar Ramakishran, president of the India Association, former president now, of the India Association of PA. Dr. Serkelem Girma, president of the Public Health Officers Association of Ethiopia. Lindsay Milkarek, president of the Physician Assistants for Global Health. Edwin Lebalo, former president of the Professional Association of Clinical Associates, PACASA, that's South Africa. We have Paul Kiatereka, president of the Professional Association of Clinical Associates of, president of the Medical Clinical Officers Professionals of Uganda. We have Masood Rama, interim president of the Bangladesh Medical Assistant Association. We have Kolombe Bizirumei, president of the Burundi Clinical Officers Association, and I have to state here that it is GACOPA that helped Burundi form the association. And even right now we are in the process of helping South Sudan form the association. Anthony Asariako, our big man here, president of the Graduate Physician Assistants Association of Ghana. They have two associations, one for graduates and another one for, I think it's the general one. Then we have Theophilus Fire, president of the Liberia National Physician Assistant Association, was represented here by Ofana. Samuel Omwony, acting president of the South Sudan Clinical Officers Association. Dan Uitonze, very intelligent, president of the Rwanda Medical Clinical Officers Organization. Fenwick Mudanya, is the president of the Society of president of the Society of Non-Physician Assistant Anesthetists in Africa. He's also the president of the National Association for Anesthetists. Ephraim Anja Adu is the president of the Society of Community Health Technologists and Scientists. So those are the people, that's how we formed that, union that is bringing all the presidents, and some are yet to join. We are reaching out to others. So today, we are having this engagement with the presidents, chairs of all those associations, together with the members here. And I know our able chairman, the chairman of the Kenya Union of Clinical Officers, will take us through this session, and it should be short. It will take around 15 minutes. Then we'll now do the awards ceremony. Then now we will break. But before that, we will also announce, we will make some major announcements before we break, together with conference resolutions. So present today, physically, Solomon Chomba, president of PAUM. He's a very big man. He talks to the vice president directly. Just outside here, we were talking to the vice president of Malawi. Come. Who is also a clinical officer. The vice president of Malawi is a clinical officer. Yes. Correct. Pabo Sebetso, acting president of the Botswana Clinical Officers Union. Scott Smalley, president of the International Academy of PA. Agnes Mashiza, representing the president of the Clinical Officers Association of Zimbabwe. Neba Jones, president of the Clinical Officers Association of Zambia. We have Margaret Maina representing GACOPA East Africa, representing Serkelem Girma. Vivian Zame will represent KCUA. So those who are already online, virtually, Stephen Mudhama of Kenya, David Olusegun, President of the Nigeria Society of Community Health Practitioners, Ephraim Adu, Pesha Pila, President of the Professional Association of Clinical Associates of South Africa, Daki Rama Adhikari, who is also the President of the, is it Bangladesh? And also we have the President of the India Association of PA, who was a keynote address. We are sorry for those technical issues, but she's online. Maybe you can project so that. Yeah. So to take us through. Yesterday, privileged to get information that the WHO elected a new director, Dr. Fodule, who is the current MP for Kigamboni in Dar es Salaam. I've known him for so long, and I also offered the congratulatory message to him. And having the first African Leadership Symposium
usually does. Now see, you need to see your hands up. Very nice. Yes. Thank you. I think now we are together. So there is a lot we are talking about. What we want the institution of GACOPA to do for us. Another question is, what do we, as the individual officers, as the institutions, representing our different countries, then need to do to strengthen GACOPA so that it can deliver that which we want it to do for us? I think that is what is on this of what we can to help us able to get a resolution on. I don't know why the president, the president or the secretary, the vice president, that's part of the part. Thank you. So I want to give the panelists an opportunity to introduce themselves and as you introduce yourself,
So it gets like to become a physician assistant, you need to complete a 4-year bachelor's degree program in the university, and course is accredited.
Yeah, pardon me. Please allow me to clarify. Yeah, what I need you to tell us is how do I become a member of GACOPA? What are the categories of membership? You tell us if your institution, your association is a member of GACOPA as per the procedures.
GRAPAC is actually one of the founding corporate members of GACOPA. So we incorporated the entire membership of our association initially, and then later we brought on the Ghana Physician Assistant Association. So as long as you belong to any of the organizations in Ghana, you are an automatic member of the organization. And currently we have about 6,000 on the register, and about 4,500 or 5,000 in both public and then private employment. The sensitization has been there. Our coming was as a result of the clearance of the National Executive Council. We are here and streaming, they are responding. And we believe in Ghana that most of our national issues also have an international bearing. And so decisions taken at the international level can easily affect the national level. And so that is, for instance, with the categorization, at a point at the National Labor Commission, where they refer to us as paramedics. And paramedic classification is international. And so this is what we believe in Ghana.
Yeah, thank you. Allow me to focus you. Now the last part. What are the categories of membership in GACOPA? Can I join as an individual member or an institution?
Okay, for GACOPA?
Yes,
GACOPA. Okay, thank you. GACOPA, we have three categories of members. We have ordinary members, we have associate members, and honorary members. Now, an ordinary member is what now we are coming to describe as either through an institution or an individual member. The person or a PA analog, that is an ordinary member. So if you are you are a clinical officer and you are or a PA, by that fact, when you file, you become an ordinary member. And most of these ordinary members are filed onto by their associations or individual what we call registration. And associate members are people who are not clinical officers, but they have contributed signal service to the organization. Some of them are lecturers, teachers, they may be policy makers, or there are people who have GACOPA at heart. They can sign as associate members. Then honorary members are people we honor, but they have not requested to be members. They are not ordinary, they don't fall in the category of associate members, but we have seen that they have been, anytime maybe a parliamentarian thinks of, or it's at the Parliament House, argues and issues of clinical officers or physician assistant, they always speak for us. Maybe a particular government or organization will always advocate for us. They are not our members. By this, GACOPA will honor this person as a member. They are not subjected to pay dues. Honorary members, they are not to pay dues, but associate members pay dues, and then ordinary members also pay dues. And that is the categories of membership we have. And by this, I have said that you can come through an individual registration or through your organization submitting you. There are people who don't want to belong to any organization. They can also apply and they will become ordinary members.
Okay, thank you. So we start with my brother Chomba. You tell us who you are. You tell us about your organization, whether they are members. You have been told the categories of membership. So in 1 minute, so that we can finish up, then we go to those attending virtually, and then we get into the other thematic areas.
All right, no, thank you so much. I am Solomon David Chomba. I usually say I possess all kings' names. Solomon David. Yeah, so I am the president for Malawian clinic officers, the medical assistants, and the dental therapists. So PAUM is actually a trade union that represents these cadres, and it has a membership of over 8,000 in this category, that I've given. Also, we have the clinic officers at diploma, and then we have the clinical officers who are registered as associates at our council, but they are still officers in the ministry at BSCC. Then we also have some specialized clinical officers who are possessing clinical master programs, and then we also have the medical assistants who are certificate holders, but we are soon phasing them out. I think any time from now, because them out. Then the dental therapist is diploma holders. I think that's all what I can say. I don't know if I've missed anything.
So are you members of GACOPA? Have you subscribed?
Okay, as for GACOPA, I'm so proud, like my brother said. I think PAUM is one of the founding, part of the founding organization of this global body that we're so happy and very proud of this time. GACOPA, I'm one of the executive members and the deputy director of communication in GACOPA. In terms of membership, ideally by PAUM subscribing or being represented, automatically all our members, they form part of GACOPA. However, there must be solution that has to be made so that at least that membership can also contribute something to GACOPA, which PAUM I think is more than ready over with the 2,000% support. Thank you.
Okay, so what we are saying is that we are members, but not yet subscribing.
Okay, so for us, our members subscribe to PAUM. So the assumption is by PAUM becoming a member, which means PAUM is supposed to pay an affiliation fee to GACOPA. So by paying that affiliation fee, it is paying for all our members. Because we look at the feasibility of our members, making these subscriptions to GACOPA, it might be a challenge. Thank you.
Thank you.
Good afternoon, everyone.
Good afternoon.
My name is Thabo Sebetso. I am the Vice President for Botswana Clinical Officers Union. Our union was officially registered in 2021 within the laws of Botswana. Currently, our membership is open to all the doctor's assistant graduates, current students who are enrolled with the institution that is training doctor's assistants. And with the numbers, we have about 240 assistants who automatically, when they finish school, they become our members. We don't have the statistics for the number of we have, but in terms of membership subscriptions, as you are all aware, our members are not working. We haven't really put up figures for them to register any fees at the moment, but these are some of the things that we are yet to sit down as an executive, discuss and see how we take them forward. With regard to GACOPA membership, because we are also affiliated to GACOPA, but just like my brother was saying here, one of the things that I suggested to our president was that maybe looking at the number of the unions that we have, individual members, we can maybe say that, for example, the Clinical Officers Union has around 200 members. Say that by the time we in subscriptions, can say that for every dollar member is $1 USD, it will be around 2 USD, maybe you can say maybe for a month or so. So these are some of the things that, like I'm saying, that needs to be looked onto, and then see how we can take them forward.
Thank you. Neba.
Good afternoon, ladies and gentlemen.
Good afternoon.
My name is Neva Jones. I am the president of the Clinical Officer Association of Zambia. As you may be aware to say, clinical officers in Zambia is a generic name in which it houses various areas of specialization, in which you've got anesthesia, got ophthalmology, got mental health and psychiatry, got also the aspect of dermatology and other specialties that are included. So when it comes to the total memberships that we have apparently, we've got a span over 22,000, in which out of that number, about 8,400 are currently working. That's in public as well as private. And when it comes to the aspect of our members subscribe centrally, especially those that are coming from the public sector, in which apparently we are still struggling with those that are coming from the private sector, knowing to say of the modalities that can be used. But I'm glad to announce to say, apparently as an association, we have come up with some sort of some memorandum of understanding with various banks, in which we are going to be on the aspect of subscription to cover those that are coming from the sector. We are ordinary members of GACOPA, but I'm glad to announce to say we are demonstrating commitment being able to, but having this. And on top of it, again, we are committing also ourselves to pay the membership fee also that is pertaining to GACOPA subscription. I think that is. I think that is all for.
Yes, Agnes.
Yeah. Waiting to see if the Mr. Chair remembers my name.
I can't forget.
I'm Alice Mashija, representing the Zimbabwe Clinical Officers Association of Zimbabwe, being the Secretary General. What I can speak of the Clinical Officers Association of Zimbabwe, our clinical officers are demotivated, should I say that? And the association holds about 75 clinical officers. And of the 75 clinical officers, we actually include our retired generals because they were trained as clinical officers. They offer their services in their own surgeries and some in the private sector. So as far as subscription is concerned, they are supposed to be paying, we are supposed to be paying $5 every month to sustain the association. But currently, nothing was being subscribed in our country. What we actually do is that people will fund what needs to be done on that given time. If we are to visit somewhere, if we are to consult those who want to be consulted, people will fund things as they arise. And as far as GACOPA is concerned, we are just ordinary members, hoping that we will start to subscribe as soon as possible, because we have seen the effort and the support that we are getting from GACOPA in trying to iron out the discrepancies that we are facing in Zimbabwe. So, starting with me, we will subscribe. Thank you.
Thank you. Yes, Vivian.
Thank you so much. Vivian Zame from Kenya, representing the Kenya Clinical Officers Association. I serve as the National Treasurer. I'm happy today to say that as a Kenyan team, we've had quite a commendable structure when it comes to clinical officers. And just to give you a preview, we have what we call the Clinical Officers Council. There is so much concerned with training and registration of the practice, and we subscribe to a certain amount of fee that we normally pay annually for our licensing. An amount of around 3,000, sorry, each year. Then we have what we call the Kenya Union of Clinical Officers, where we also subscribe on a monthly basis. They pay 500 shillings. Then we have the association. They also again pay 500 shillings. So I think from that we can be able to see that for the Kenyan clinical officer, the structures have enabled us to be able to progress. And for us participating in GACOPA, we have the ordinary membership where individual members subscribe to GACOPA. But as we had said initially, we are looking forward to having the affiliations that we have in our country to subscribe. I think basically will be more on the associate. Just as I had retaliated some time back when we were starting the conference, and I think it was echoed by most of us from Kenya that if we can be able to have these associations and unions from the different countries subscribing at a fee to GACOPA, this is going to give us a very big niche and we'll be able to have funds for GACOPA. So at the moment, for the Kenyan clinical officers, we are on ordinary membership for GACOPA. Thank you.
Thank you. Margaret?
Can I appreciate her? Because I see you want to clap. Yeah. I think I'll request us to appreciate the Kenyan delegates who just came to this conference. Just a request. Appreciate them. So my name is Margaret Maina. I'm representing Sekarem, the president for GACOPA East Africa. The reason why I said we appreciate the Kenyans because we had our first East Africa GACOPA in Zanzibar last year, and it brought it was a birthing to join 10 countries in East Africa, and we are so grateful to God about that. And from that, I know an apology on behalf of the president, because we had planned to be in Ethiopia for our second. And during that first conference, we marked every 4th of March to be a Clinical Officers Day to be celebrated. And that's one of the things we also are intentional to be doing every year in March to celebrate clinical officers. So in our structure, I think we are committed to support GACOPA, because out of that, that's why we had an East Africa region. And we are grateful for the delegation which has been made today, which is one of the things we also desired, because the president comes from Kenya. So we have full support in this vision. Thank you.
Yeah, and maybe what is the level of sensitization in East Africa?
Okay. I'll say the structure we have, in particular, having the president, we have vice president from 3 countries, the first, second, and third.
there we have our global repository where you can access over 200 scientific papers that are of and about the clinical practitioners. So it's really the place to go to find out what's happening in research. We also have a members corner where members can submit their own writings and own work. I really like this idea of a GACOPA journal. It's something that IEPAE has been thinking about, and perhaps there's partnership that we can do there to develop that further. Also, as a member, you get access to our toolboxes, which are learning pedagogies, really designed for educators to help them with their lesson plan, faculty development, putting together curriculum mapping, access. So I really encourage you to look at that. We also have on the website the global map of where we are throughout the world. And soon we're going to be having individual country pages, and that will be accessed by our members to see about the stats of the countries, to see about cross-border reciprocity, education, and standardization of our profession. We then have individual student membership, which is $10. We also then have special nation membership, which is recognized by World Bank for low or middle income countries for only $20. So normal membership is $50, but our special nation membership is $20. And then we have individual student special nations for a zero cost. So we want to welcome students from around the globe to sign up and be members for us if you're from low income or middle income countries. We also have our corporate memberships, and that's $250 US, and that provides institutions or associations with up to 4 members who then have access to the conference and reduced rates to attend the conference and participate with us. So we, as of now, have 130 paying membership. And really, this is the first time ever in our IEPA history that we've set up a paying membership. And you heard me talk throughout this conference about supporting your associations, paying membership dues. Dues are really helpful for their
paid for membership.
Okay. Thank you very much. I think this question, if the Director of Finance was here, he would have tackled this question, but since he couldn't make it, I think I'll do that. So there's an ongoing discussion about all of these, the dues, how to formulate them, how to come out with one that cuts across so that some people will not feel like they are being surcharged and some people don't feel like they are being undercharged. So there's an ongoing discussion. Now, I'll just give a slight preview into that discussion because that's not been finalized yet. Yes, so that would have come with the launch of the roadmap that we are talking about, because it all eats into that same document. So what we are discussing now is that every association that's a member of GACOPA, every year you pay between $1 to $5 on the head of every member. Every year you pay between $1 to $5 on the head of every member. We don't want to say that, okay, this association maybe association will pay $2,000 to GACOPA every year. No. If you have 20 members, 20 registered members, you pay $1 to $5 every year on the head of every member, so that it will be on the same, on that level for every association to be able to afford. So that if you have 5,000 members and we ask that every association should pay $1,000, you will feel like you are being undercharged. But the association that has going discussion, every year, every association, the number of members you have, registered members that pay dues to your association, you pay between $1 to $5. We are going to come up with a number, but that's the range, between $1 to $5 on the head of every member to GACOPA to help, facilitate the movements and processes we do here.
Okay. Yeah, thank you. So we'll have different, that means we are going to be members through our associations.
Yes.
Or we say institutions.
Yes, institutions.
Will that be only the association, or does it include the regulatory bodies and the unions?
Well, the associations will bring in the ordinary memberships. You understand? Yes. So if, let's say, in Kenya, let's say KCOA becomes an affiliate member of GACOPA, and KCOA is paying dues on the heads of their members to GACOPA. I think if the regulatory bodies want to come in, what they will do is to maybe support, because if they also pay dues, it is the same clinical officers that are being regulated by the regulatory body, and they paying on the head of every clinical officer will be like paying times 2, because then KCOA will be doing that to GACOPA. And if the regulatory body does the same, then we like they are paying twice for the same people. So the one from KCOA, from the regulator, can come in as a support, and that one cannot be capped.
Yeah, but the question I know that will be coming from the audience is, does that mean it's only the associations then that can become members of GACOPA?
No. Okay, the president wants to add.
Maybe I can just add something on that.
Yeah.
Not everybody will be members of association, because or organizations or unions or even universities, some will opt out, because joining those institutions is voluntary. So we'll have provision for membership through associations, through unions, and then the second clause, if anybody is not a member of the above, then that person can join as an individual. So I think that is clear.
Yeah, I think the question I was asking was, because he said association subscribes, then if the regulatory body wants to come in, they can chip in support, and to support the association. And so the question was, will the union and the regulatory body be full members?
Yes, they'll be members.
Okay. Yeah, thank you. And as we continue, I don't know if Xavier is in. If you have any contribution or question, please write it down so that it can be collected. And then at the end of this, I think one person can be able to read out for us so that we don't take a lot of time. Oh, the online are back? Are we okay? Okay. They can hear me? Yes. Our online attendees, you can introduce yourself. Yes. Yeah, so we can start with, that is Modama Stephen talking. Just an introduction. Yeah, thank you. Thank you. Then we have, is that Olusegun? Yes, I think we can go to the lady, and pardon me, I'm not able to see your names. Gumadhi. Yes. Yes, we can hear you. Please introduce yourself. Tell us about the association in. Yeah, proceed. Thank you. Then we have, I think the next one was it Olusegun? Technical team. You can bring the next one to the screen so that we can see the name. DN. I don't know, I can't see the name there. Anybody who can? David. Yes? Yes, David. If you can hear us. Okay. If we can't, then I think we proceed. So membership is very important, and I think we need to have a resolution on this. Now that we have agreed that all of us do not actually subscribe to GACOPA, and that we have also agreed that this is very important for financial stability, and so that GACOPA can be able to implement the vision that they have shared with us. What timeline should we give ourselves then, so that we can subscribe? Yes, Vivian.
I just want to bring an idea on how best maybe we can do it. If we are to place $1 on an individual for the association to be paying for the GACOPA affiliation, it might be very expensive to some countries. So my suggestion is, if we can have maybe a rounded figure or amount for associations, that means you are representing your country. So maybe if you're going to say it's $250 for each country, and definitely we have different jurisdiction because of the fewer members. Depending on the dollar rate, I don't know how better we can do, but if we can say all associations that are in our countries should be a must member and pay a certain amount of money to represent the country, then the members themselves to have an ordinary membership fee. That will show commitment as a country towards the vision of globalization of the clinical officers. Thank you.
Yeah, thank you. So what you're saying is we cluster countries and have different but rounded figure for individual associations. the same way I think GACOPA has done. I think even the membership is clustered according to countries. Yes, do we have any other suggestion from the team? Yes, Chomba. Austin, you can hand over the mic.
All right, no, thank you so much. I buy the understanding of my colleague in there, but the challenge is economy is not static. Yeah, so I think that's where there was that concept of having a person that should be minimal, because I think that's how, maybe, of course I know it's a very difficult thing to come out clear, not only here, but even different organizations. Affiliation, if it becomes a challenge, how we balance up different organizations. But the one that works better is the, like for us in Malawi, we are also an affiliate, PAUM is an
Okay, Steve. The technical team is looking into that. Yes, proceed.
All right, fine. So like for in Malawi, PAUM is an affiliate member of Malawi Congress of Trade Union. So what we do is we pay an affiliation fee, and that one is dependent on the number of membership that you're having. So organizations that have a good number of membership, they're paying more. Right, so they have a formula. Perhaps maybe you can just try to borrow what formula are they using to assess an organization. But one thing is they will ask to say, how many members do you have? And then you submit reports, retains to them, say now our membership is growing, then you expect the amount also to be growing. But the charge per person is very minimal, so that it should not suffocate the organization. Thank you.
Okay, thank you. But I think we are in agreement that once we have the figures, then we should be able to subscribe. Yeah, thank you. I think the next thematic area is about collaboration and partnerships, because the vision that we have is the one that we cannot be able to achieve alone. We need partnerships with other global bodies. We need collaboration with other global bodies. And I'll start with a question, and this I'll pose to the President Yapai, because I know you have experience. Who are the potential partners that we can be able to collaborate with, so that as GACOPA, to ensure that then we meet our vision?
Okay, thank you, colleagues. As IAPAE, we're looking to partner with GACOPA, as we've done already. And then we look to partner with WHO and their educational arm. They're talking about starting a WHO academy. As you're aware, I presented on the WHO competency framework for universal health coverage, and it's the first time there's a competency framework that addresses the paramedical practitioner, our current name, in providing competencies. So we're partnering there. We also are looking to partner with each of the different associations that are in the countries. I presented yesterday the 62 associations there, and I apologize, I forgot the Kenya Clinical Officers Association. They were on my previous list, but I've now included them. And other associations we may have missed, we want to get included. And we really also want to partner with the academics within the countries. So we're making inroads to the academic institutions that are teaching. As I said, through our of Africa, and he's from Kenya, and he's making inroads into the Kenya medical training colleges. And KMTC has many universities, colleges across Kenya, and so we're making inroads into there. And where we can tap into these locations, we can really make advances. I really liked GACOPA's recommendation of NAEPA, the National Academy of PA Educators, and that each country can have a National Academy of PA Educators of Kenya, National Academy of PA Educators of Malaysia, National Academy of PA Educators of India. This would really go a long way for us, IEPAE, making connections, and of course through that, GACOPA would be connected. I'm very pleased that Ms. Gomathi is here on the call. She is the new president of the Indian Association of PAs. PAs have been in India since 1992. They've only recently been recognized by their government with the Indian Health Professions, Allied Health Professions Bill, which passed in 2022. And I'm pleased that through our IEPA conference last year in Gandhinagar, India, where we co-hosted with IAPA, that they've formed their PA Academy of Academics. And they now have a WhatsApp group, PA Academy of Academics. They're meeting with all their PA educators in India because they're forming a national curriculum, a national standard framework for their educational programs for their bachelor's and master's. So they've already formed their India, NAIPA, the Indian National Academy of PA Educators.
Thank you. So the president has talked about the collaborations and the partnership they have established under YAPI. My friend Agnes, yes, what are the strategies? Do you think we can adopt those ones? Do you think there are probably more that we can be able to include as GACOPA? And what do you think should be the engagement strategies to ensure that it works?
Thank you. Representing my country, I think we can adopt what Scott has been explaining. My input won't be of significance because we are struggling ourselves. We have not many people, we don't know much. So our input might be of significance because ourselves, we are still trying to connect. We are still trying to find how best can we do things around, how best can we stand up like a child who will be learning in like day, nana. Then, so we are still on that first step. So for us to give concrete advice, I don't want to lie. I will speak like the parliamentary yesterday that I don't want to commit. I might lead people astray because we are still learning. Thank you.
Let me support my colleague. One strength that we can have as GACOPA is to look at these regional representations and where some of these associations exist already, or regional, very strong African network of clinical practitioners. And that's something that we could revise again, and perhaps that's through GACOPA. We have an African chapter, or we revitalize that. And Zimbabwe was a strong member of that. You know, we had a meeting, it was very strong. Educators tap into the European network of PA. Instrument is the current chair of that, and they're trying in the UK and standardizing the curriculums and education, and through that there may be then cross-border reciprocity that can happen. We also have, of course, we've heard of West Africa, and West Africa Association of PAs, and so that's a really strong region here that we can look to. And then there is another international organization that has been strong with Canada, United States, Europe, and some African countries called the International Physician Associate Organization, IPAO. And that has some connection through the AAPA, when the AAPA has their annual meeting in May. And we also have our annual online meeting of IPAO. And many of our members here in the room have attended that online session. So I think GACOPA can reach out to some of these. There's also a Society of European PAs, CIEPA, I think, and there's also the EuroPAC, the European PA Certified. That's another organization we should reach into. I'm trying to think Oceania, if they've organized anything yet. I don't think regionally they do, but there are many countries there and island countries we need to reach out to. Marshall Islands has the medical extension officer. Fiji had such a program. They have them working there. We have many colleagues in New Zealand that are starting the program. We need to reach out to Oceania, include them. And then I also want to really challenge us to also reach out to South America. South America and Guyana, the country of Guyana, have medical extension officers called DELEGATES. They've been running for many years down there, recognized doing really good work. There are other countries, Brazil, that do have what we understand is perhaps similar to a PA. Mexico may have this. I think someone mentioned earlier about languages and how languages may be limiting us from connecting with our colleagues. So I would encourage us also to bring in some colleagues, these various languages for us to connect to. We talked about how we need lawyers on board. Maybe we need translators on board. This meeting should have translators so that we can be online translating to those colleagues. In Africa, many colleagues speak Portuguese. In those countries, Mozambique, Angola needs to be represented here. Perhaps we also, for our West African colleagues, need translation into French, so that can be connected. So it's something for us to be thinking about as we reach out to our stakeholders. How do we access and increase involvement through language through identifying and finding where they are. Thank you.
Yeah, thank you. And probably apart from those, we also have others like the CDC with their branches across the continents. Of course, we talked about the WHO, the UN, and all the other health related. And I believe they'll be giving us the strategy on how they are going to be engaging these bodies. Mr. Neba, you heard about the governance structure of the GACOPA and the proposal to review. And what I want to ask is, do you feel that the governance structure inspires a feeling of belonging that would enhance the synergy and bring together the clinic officers and physician associates and analog across the globe? Or do you think do you think it does that? Do you think also it can be enhanced?
The current governance structure, I think it doesn't answer. I think we need structure that is inclusive. I mean, when you say global, it means we belong worldwide. So it should be able to resonate and answer that structure. So one of the things that I wanted to tap in as well is on the strategic framework. We need a number of policies. I think some of us, we have not seen the constitution of. We don't even know the strategic plan for GACOPA. So for us to be convinced and to convince our member, I mean, we need to be privy to these important documents. So at the end of the day, our members are going to be able to be convinced when they have understand the works that GACOPA also are doing. I think personally, as an association, we do recognize and recommend the works that are going on for GACOPA, especially when it comes to this unifying of curriculum and the aspect of unifying as well of the name, the aspect, of course, of having some sort of common regulation. So we know for us to partner with various bodies also, we need to have all these legislative reforms that are supposed to be within, which are supposed to be in place. So my submission is that the current structure is not inclusive. If we say we are global, may it be represented as so.
Yeah, I think the vice president suggested that they want to try and open up and have a vice president in each of the continents. Do you think probably that now satisfies, or do you think there is more enhancement that needs to be done?
I think that might be satisfied, might satisfy the need that we are having apparently. If you have a president from GACOPA who is in Zambia, it means you have formulated somebody who is representing now GACOPA, not just the association that exists in that country. So you've got a direct contact as GACOPA to that country. And that, of course, might help us to enhance, one, on the membership subscription. As we know to say, like where I come from, Zambia, we have got bachelor holders who are called the Zambia Medical Licentiate. And we've got the COAs. The COAs have got also other affiliate members. So it happens to say the bachelor levels, they don't feel to be part of GACOPA. Meanwhile, they are clinical officers. So if you have a member now at that level, it means it will be a representative that is going to unify the representation of GACOPA in that particular country. Doing so might enhance good structure in various countries that is going to support nationwide structure that we're talking about when we say we are global as GACOPA. Thank you.
Yeah, thank you. Mr. Chomba, other than the membership, where else do you think GACOPA can be able to mobilize funds to implement its strategic objectives?
All right, no, thank you so much. I think projects. I think GACOPA has the capacity to run up very important projects. So if we can go into projects, I feel like we can get in some funds. Research is one of the issues as well. I think most of the issues that we're discussing in here, they are also showing some research gaps. So as GACOPA can champion that, and then we'll find some resources. Even sometimes we can also do some fundraising activities, you know, let's say from different countries, right? Let's say no Malawi conducts a fundraising activity on behalf of on behalf of GACOPA. Those things are workable. You know, I think these are the three suggestions I can bring forward.
Thank you, and probably one of them is the scientific journal that Vivian was talking about, because it will be a money-making venture. I'm told we have the president for the Association of Clinical Associates from South Africa online. You can unmute and introduce yourself. Tasha. Tasha, if you're getting us?
Good afternoon, everyone. Can you hear me?
Yes.
Can you hear me?
Yes, loud and clear.
Thank you, thank you. Good afternoon, everyone. I'm Tesha Pillay. I'm currently the newly elect chairperson of PACASA. PACASA is the Professional Association of Clinical Associates in South Africa. I'm currently employed at Walter Sisulu University, one of the first universities to start the clinical associate program in South Africa as a lecturer training clinical associates. It's good to be here, and I'm glad I'm getting to hear everything that's happening. Thank you.
Okay, thank you. Gonandi, if you can hear us, in India and generally in Asia, what is the level of sensitization and acceptance of GACOPA there? And do the ordinary physician associates or analogs understand what GACOPA is and its objectives? Yeah, I don't think she's getting us. I think she's saying I should put my mic closer to my mouth, probably meaning that she can't hear me. Yeah. And I think now we can take questions or contributions from the team so that then we can wind up. I know we are standing between you and lunch. And if we continue, the numbers in the room will continue going down. So I don't know who is going to assist me. Yes? Who is talking? MS? You want to say something? Shoka, you can help me with the mic? So okay, I don't know if he's contributing or it's by mistake. So we take questions. Do we have questions, contributions to any of the areas that we have been able to cover? Are we tired?
Any question? Sure.
Can I speak now?
Yes, yes. Please proceed.
I have a question. I think it was about the understanding about the GACOPA and its activities in India or in the other Asian countries.
Yes.
Unfortunately, not much of it through our past president. Or probably I should say that I was not very active in the association previously. I can only speak for myself. But Scott had got me to a lot of good things about that. In one family and make a movement more to it between countries. So that's an awesome effort. I think I really hope that other countries also join this effort. And the funds are also needed for this activities work together and see how we can do this family.
Thank you. So we seem not to be having any questions or contributions. Do we? If we don't, then we have closing remarks for just 1 or 2 minutes from our panelists. And then,
Yes,
yes, Stephen. Proceed. Allowed.
One of the things that I would commit to was an aspirant once I elected the president of the Kenya Clinical Officers Association is to popularize the advantage, enthusiasm, and aggressiveness of Kenyans, others clinical officers, and ensure that this popular what the executive in their activity, such as association and fee. I am so proud that necessary support. So I welcome the idea of friend association and cooperatives joining hands to ensure that the association is supported. Mandate. Something that I would encourage all members attend as delegates global, make sure that the global association is popular and marketings so that purchases are bottom up.
Thank you, Stephen. I think we can take the closing remarks very fast and then we hand it back to the secretary who is not in the room. We start with the president.
Okay, it's really appreciative that we've come together, and I'm just excited to see what's happening here online and in the room. I think we're up to 12 to 14 countries that have been represented throughout this conference. I mean, it's just so incredible. We've really done so much. 2019, I became president, and we held our conference in Switzerland. We really started a global debate. That same year was in 2020, the next year was the start of the Rwanda conference, where things were happening for GACOPA. Things were really coming together. I'm just so impressed with what's happening. And I think it's been said here and other conferences I've heard too, is that if you're not part of the menu, then you'll be part of the dinner. So we really need to be part of the menu, and I think we're stepping up to be on the menu. And we're on the menu now. We are global, and we are recognized, and we need to embrace that now. Enough of we need to get recognized. We are recognized, and we are here, and we are the global voice. So let us set that voice very loud, and let's be very proud. Clinical practitioners, clinical officers, physician assistants, around the world are united from here forward. Thank you.
Hey, I'm grateful to God again because being a practitioner and also a teacher has made me to be on the two sides to see when I'm teaching, I'm able to tell them there's hope in the marketplace, that you work hard, get the knowledge, skills, that there is a place for you in the marketplace. So I am grateful to God that we are synergizing this dream. Thank you.
Thank you so much. I'll still echo so many things that we have said, but by the end of the day, each and every one of us who's seated in this delegation is the pace setter to make sure that we market GACOPA. So let's keep the pace. Let us run this race and make sure every time GACOPA calls for us, each and every one of us will stand. Thank you.
I think what I would have to say now is that what brought me here to this conference, it was because of the effort and the visibility that GACOPA had shown in my country, trying to solve the challenges that we have. So what I think is, if GACOPA continues to work hard, to be visible, it will be easy to market something that is visible to people, and it's easy to market someone who is doing something that everyone can applaud. So my take-home message to GACOPA is that they have to continue doing the good work that they are doing, and upon doing that good work, I strongly feel that they can copy some of the things that have been done by unions or organizations that are as big as Commonwealth. What Commonwealth has done is in trying to unite in nations and countries, they do offer what they call fellowship, some fellowship opportunities. In such opportunities, you have, like for example, people from Kenya going to Zimbabwe or going to any other country for a brief visit, like for a week or for 2 weeks, try and impart what they have to another country and they learn from that country. And I think through doing that, we will continue to globalize our practice and we will be visible. Thank you.
Hey. GACOPA is a deal breaker. That's what I can say. Why do I say it's a deal breaker? I'll take an instance to say clinicians are the least appreciated cadres in most of the countries. I'll take that in Zambia. Just a few weeks ago, we had an instance in which the Zambia Medical Association came up with a statement saying, we had saved the purpose, and they were calling on the government to abolish the training of clinical officers. What did we do? We used Austin Oduo, of course, had him to write a statement pertaining to the response. 2 days later, we had also our press conference in which we saw some sort of tremendous changes coming in. One of them is that that officer almost got fired and transferred. We are primary healthcare keepers. As GACOPA, we really need to synergize in many countries and support each other. By supporting each other, we are going to be recognized again globally. So it takes our effort again there. We can say so much things, but if we're not doing anything towards that, the behavior is not existing. As the Clinical Officers Association president, I think we'll continue supporting GACOPA. And I can assure this forum, this August House, that our subscription will be done this year in fully as well, just to start from. Thank you.
Thank you very much, Chair. From my end, I can say that in terms of advocacy, GACOPA has been doing very well. So we just need to take these conversations forward. It should not end in this conference. I'm happy that the President announced that it's going to be that legislative, I mean to say for the leaders of the unions as well as affiliated, see how best we can GACOPA global. I'm sure that the organization will do well.
You, Solomon David, the wise man, you have the last word.
All right. No, thank you so much for recognizing me, because Solomon was really a wise king. Indeed, I think I would like to say that being someone who saw the conception and the infancy of GACOPA, I would be so happy to say now that GACOPA now is moving. He's an adult, right? And not just an adult, I think it's a big elephant whereby each and every country is supposed to take a bite, but we cannot exhaust it, right? So where we are, I think we must feel proud of ourselves together because we're all FOPA, right? And then as Malawi, I think Malawi is in full support. Even that's why even our ministry, Malawian government, made a declaration that this program, when you hear something about GACOPA, Chomba is there. So it's Malawi government that funds some of us. You know, so I believe if we can take the same to our relevant governments, you know, preach this message about GACOPA, I think I can see life from GACOPA. So otherwise, I'm so happy that we are moving quite very well. Will still really commit to support, with the affiliation fees because it's already known. Our members know. Thank you so much.
Yeah, thank you. Apologies, we will not be able to take the last word from our virtual attendees. So as my panelists exit the stage, please appreciate them. And I'm sure you can do better. So, to ensure that we facilitate GACOPA to achieve its objectives, which of course is going to be beneficial for the profession. Thanks a lot. And on behalf of the presidents and the chairmans of the world, I want to give an affirmation that we are going to support you.
Thank you very much, Chairman Peterson Wachira. Please put your hands together for him. It was a very involving, informative, insightful session. Yes. A few announcements before we go for lunch. The gala dinner is on for $25. If you have not paid, you can make your way to the registration desk to make payments. At 4 p.m., we are going to have the much-awaited exhibition football match between GACOPA 11 and Botswana 11. If you want to come and witness football, when I say football, proper football, come and see the likes of Austin Oduo, come and see the likes of Anthony Asare-Akon, Dr. Mike Amof. If you want to see Scott Smalley playing football, join us at 4 p.m. It's going to be a very interesting football match. I am the goalkeeper, so I know what I am saying. Yes. So gala dinner is on for $25. You can move to the registration desk and make payments. Football match is on for 4 p.m. Let's go for lunch. We are hungry. Thank you. So you go get your chits at the registration and then you go for lunch.